Yes. One, two. Maria. Elizabeth. Hello. Check. Okay.
So yanjye yabonye ubwiza bwawe, niyo ndirimbo yanjye, uri mwiza Yesu we.
So tumfunye.
Ubasha kubasa nakureba. Ijambo ryawe riganje umutima wanjye. Francis wali mu motoka nalese earphones.
Tuzifune earphones.
Hey, that's what best friends do. Hey, that's my best friend, but your homie, you're real one. That's the fact. You fakers out there, best friend, knock up. Let me tell you like it is. No other thing there is. You catch a bullet for me, you know what the feeling is. Did the only thing anybody ever really wants to be themselves unapologetically, because life is short to be happy while here, and so to play it off without a best friend near. Hey, that's what best friends do. Hey, that's my best friend, but real homie, you're real one. That's the fact. You fakers out there by straight knock up. Let me tell you like it is. No other there is. So catch a fool for me, you know what the feeling is. Yeah, 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 yeah. Yeah, 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 yeah. 40 bottle in Dubai. Flores. Jerry. Chichi. Flores. Yeah, 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 yeah. Yeah, 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 yeah. 40 bottle in Dubai. Flores. Showcase. Talent. Ninye. Apuli. Okingen. Highness. Toro Messiah. Neto Bulaya. Tindulaya. Nintera rapo. Baita huntera mbatera fara. The pump yavera what? My father passed on when I was only 5 years old. No one could take care of me. Most relatives said no. So my uncle tried to support when my mama could fight all alone. In this life, I feel like I'm a narciso. Never leave me, never leave me. Though my mama or papa forsake me, he'll never leave me. He'll never leave me. He'll never leave me. 'Cause the water come and gets me, he'll never leave me. Ha. Ulira. My father passed on when I was only 5 years old. No one could take care of me. Most relatives said no. So my uncle tried to support. When my mama could fight all alone. In this life, I feel like I'm on a seesaw, always watching. Never leave me, he'll never leave me. Though my mama or papa forsake me, he'll never leave me. He'll never leave me, he'll never leave me. 'Cause the water come and gets me, he'll never leave me. Ha. Hey, that's what MCI does. Hey, that's
So,
MCI
Jeremiah,
real homie, you're real one.
I just want to
That's the fact.
confirm that everything is okay here. because,
Everything is covered.
What I need is clarity and a crystal clear sound. Simanyi wano. Anyway, we may add one handheld microphone here. Yes. And then we shall have another microphone for the... It can stay there for now, no worries. But when these guys come here, we may need one other handheld microphone.
Okay.
Mr. Muchibi, I don't know if everything is okay with you. Omwami ono agenda naye yandikutadde mu breakout room. Omukulu, teyandigenze lumu mu breakout room. Jeremiah, okay. So, onje? Jeremiah ndeka. Kubulire?
Bukenya wadde agambye. Tugenda teekako ne wano ku Zoom. So sina
ku YouTube ku Zoom.
Ku Zoom nawulidde naye ajogerako.
Anti kyembadde ngamba omwami ono naye alabika
sinafuna logins ezo. N'ekirala waliwo kye njagala onnyambe katono.
Kamusabe gundi wano.
I rap for you.
Eh?
I rap for you.
Go ahead.
Nine wa Francis waba wali.
Tiwaliwo ekintu kye njagala nkugambe.
Hey, that's what
Rapping.
I rap.
Waliwo ekintu kye
Hey, that's what MCI does. Hey, that's a real homie, you're real one, that's the fact. Real fakers out there, but straight no cap. Let me tell you like this. No,
Yo, I wanna get to this street and put us tonight.
Never stand back when I make a bad
When you
book.
look at Kizito laughing like that, I wonder why Kizito's laughing like that. That's why the guys is stole his bag. Yo, listen.
Wasibye sebo? Wasibye sebo? It's closer than a brother, you're a brighter light. Call me in the middle of the night, you get in my novel, that's alright, girl. You know me better than I. You got my back anytime and day. Juggle up, bashishi. Bashishi. Bumba, bashishi. Eh. Juggle up, bashishi. Bashishi. The mama gave to me, and I get to Tijambaria where can do mutima one day. The number one danga mere nawe. Wahindu yobuzima one day bo say yes way. Uri mwiza chane we. Uko wansanze, uko niko wangonze, ubu mumvane sanze, uri mwiza chwe. Amaso yanje, yabonye ubwiza bwawe, niyo ndirimbo yanje, uri mwiza cyane we. Aho aho mwiza mwiza kureba nakureba ali ono kati yakufaanana gwe wateeka ku gundi omulaba yenakateebali yakufaanana ijambo lyawe liganje umutima wanje na n'umwe wankunda nkamere nawe wahinduye ubuzima bwanje bwose yesu we uri mwiza cyane we uko wansanze uko niko wankunze ubu mumva nisanze.
Yes, Nalongo. Ndikiriya sina buzibu ogamba otya?
Ndi bulungi.
Wangi nyabo?
Adi nkukyekingako.
Neyanza nnyo nkyali eno Entebbe. Naye naatera okumaliriza.
Kale.
Mukama akukuume. Wano waliwo surprise yo bampadde ebintu byo abimpadde kakubuuzeeko.
quality. I was very happy during that conference, and by the way, there was a declaration. In that declaration, we are all declaring that we are going to get our own resources. So I declared on your behalf. Yes, I had to declare, whether you are happy or not happy, all the 10 countries, 11 declared. And I have the declaration with me. And when I do it, I have done it on your behalf. And I was saying that I was happy. Happy because we need quality even in our financing. We need to be people who are realistic, that every dollar, every penny should translate into something tangible to touch the lives of the people. Every dollar, there is a lot of wastage in should translate genuine into wastage something tangible at every step to touch the lives of the people. There is a lot of wastage in this country, genuine wastage at every step, every process. We have wastages. We need to start tightening the nuts along the lines of wastages and put in more innovation. Not only in financing, we need innovations in ensuring that our medical commodities, the products, the technologies we are using actually benefit the end user. Are we able to track our medicines up to the beneficiary? And when you're asked for accountability, can you, by a click of a button, produce accountability? We need quality in service delivery. Do we keep time? And do we do what we are supposed to do adequately? Or we all come and we practice being around. And there is a lot of being around even in conferences, because we walk in with our phones, mobile phones, laptops, and somebody is talking and we are busy on WhatsApp, SMS, you're laughing with the, people, and things pass you by. And when things pass you by, you have missed the point here, you continue to miss that point. And we pick on this, carry it with us into our areas of service delivery, and there is no quality. We are losing maternal lives because we are not concentrating, because we are not thinking, because we are not giving in enough time. I was challenging people during the conference where we were discussing blood a few days ago, the African Society for Blood Congress. And I said, for a long time in this country, we have relied on blood from our children, because when the schools are closed for holidays, there is no blood. And then when the schools are open, we are all running to look for the children, because we want to bleed them. And yet, the age for donating blood ranges from 17 to 65, meaning that all of you in this room are eligible donors. But why don't you want to donate? Then all of you will be saying, we are not sure of ourselves. And yet you are the people that are discussing quality. If you're not sure of yourself, why don't you go and find out, so that you become very sure and you know whether you can donate or not donate. Suppose one day the children say, we are not giving blood, don't come to our schools. Are we going to die? Are we going to die? Yes, we are going to die, because many of you here don't want to donate blood. So I am challenging us at every time that we are doing something and you're thinking about quality, also think about the lives of the people and think about yourself. What if it were you? I was told of a story of a pregnant girl, 17 years old, recently, severely anemic, with difficulty in breathing. Perhaps she was in failure. In a health center 4. She was put on blood. She was not improving. And she was transferred to a regional referral hospital. Upon reaching, wanted to discharge her because she has come where there are specialists, where there is equipment, where there is better health services. Now, she has come from a lower health facility to a better facility. The better facility wants to discharge her. So which one is the better one? Isn't it the one that received her and gave her some blood? The health center 4. You can imagine the irony of things and the challenges of the system in which we work. So even when we are thinking about quality and innovations, let's ensure that the products reach the people. Of course, the other areas of governance and leadership are extremely important. And you must lead by example. You must be a committed leader, not a politician. There is a difference between politicians and leaders. But there are times also when you can interchange. One time you are a politician, another time you are a leader. But it is always good to be a leader so that you inspire people to do the right things. But don't come and tell a lot of lies and then there is nothing done at the end of it all. There are many of our leaders in our health system at every level who are very good politicians. Even when we go for support supervision, they will say all the nice things, but when you go to look for the nice things, you will not find even one. In other words, they are absolutely absent and only present when people go to see them. So this conference is yet another opportunity for us to share experiences, challenges, and opportunities, and tested solutions in the implementation of quality improvement healthcare in our country. There has been a lot of effort in trying to ensure that we instill quality at every step of our work. I recall there were many hospitals where 5S was introduced and supported by JICA. One of them is a hospital where the director governance comes from, which I visited recently. And I wanted to see the traces of 5S. The traces. I'm just talking about the traces. I looked around, I tried to bend. And yet, these were serious investments in terms of dollars. So one of the painful things we go through is that when we are getting support from partners, we are all into it. When the partners withdraw, we also withdraw. And the painful thing is that we are withdrawing from our own systems. The partners come in to support. So if you withdraw with them and you destroy the system, then was it really worth the support? I really want to urge us all to be more committed. I also want to encourage the planners at the Ministry of Health to pick and take note of the various issues or innovations that need scaling up at all levels of the health system. I love the theme, innovations, and as I mentioned earlier, it calls for all of us, players in the health sector, to use these innovations, and remember I said they don't have to be expensive, amidst our challenges, to improve the quality of care. You can even use innovations to improve the lead time for procurement, lead time for requisition of funds, lead time for many things. In some of our institutions, including the Ministry of Health, some procurements can take 3 years. Can we put in some innovations? Shorten the time period, get the things out early. Requisition of funds just to go and do something. Perhaps there is an outbreak somewhere. It takes like forever. And then the minister has to run to WHO or USAID. Can you please chip in quickly, as we are still going through the bureaucracies of government? We can shorten that. And that is putting quality in our actions. It also dispels the belief that quality of healthcare services can only be improved with a lot of resources. And that is why I started by telling you that now reality has set in, and we have to demonstrate that improvement can be achieved within the limited resources. I would like to urge all participants in this conference to use the opportunity to continue highlighting and sharing the unique ways through which you are using quality improvement initiatives to improve service delivery in your areas of jurisdiction, and also to ensure that quality improvement is institutionalized at the different levels of the sector and come up with solutions that can be shared across the board. The ministry will continue to make investments in the national health system. Many of you are seeing the infrastructure that government is investing in, the health center 2s, the health center 3s, which is meant to ensure that we reduce maternal mortality and child mortality as much as possible. And I am glad that we set targets, and now we are going to launch the guidelines to help us implement the various documents that we have at hand. In a special way, I would like to appreciate His Excellency Yoweri Kaguta Museveni, the President of Uganda, who saw the need and the importance to enhance our salaries. Unfortunately, yes, everybody is, some people want to clap, others are not, perhaps others did not benefit. Unfortunately, it is very clear that the salary enhancement has not translated to better quality. It is very clear from the surveys that are being carried out by Ministry of Finance and others. It is not translating into better services, better quality, and we are yet to see if it will translate into better health indices. So I would like to appeal to all of you to do more, to sustain what we have already achieved, and also improve as we move forwards into the years. The people we serve are yearning for better results. We look forward to a time when we can work very closely with all of you through one plan, one budget, one monitoring and evaluation. And we are going to be very serious about this. We don't want any more fragmentation, silos, vertical programs. We need to integrate everything under one leadership so that we can all boast of our achievements together. And when we have not done well, we also look down on our failures together. As I conclude, allow me to appreciate our development and implementing partners for supporting the initiation and growth of quality improvement initiatives in the health sector and bringing us now to the 10th conference. We are very grateful to you all. I would like to recognize the SCAP department at the Ministry of Health under the leadership and guidance of the PS, the DG, and the Director Governance for steering quality initiatives in the sector. I would also like to appreciate in a special way the frontline health workers at the facilities who are the foot soldiers of change towards improved health service delivery that we have achieved so far and where we are going. And also to continue to remind you, especially the frontline health workers, that even as you give services, remember to protect yourself. That is part of quality. Remember to protect yourself. Uganda is a country that is very vulnerable to outbreaks. Even when the system is quiet now. Is it quiet? Is it quiet? It is not quiet. Don't we have foot and mouth disease? So it seems some of you, those who said yes are eating meat. I am sure that all of you saw the letter saying don't eat meat in Kampala. So we shall check today if they have cooked meat here. Allow me to congratulate all those whose abstracts were accepted to be presented and discussed in this conference. Finally, allow me also to appreciate those who are online, who took off time to join us in this conference. And before I take my seat, I would like to thank the following in a special way. The Global Fund, USAID, Uganda Health Activity, the Makerere University School of Public Health Monitoring and Evaluation Technical Support, that is METS program, USAID Family Planning Activity, Japanese International Cooperation Agency JICA, USAID Maximizing Options to Advance Informed Choice for HIV Prevention, USAID Social Behavior Change Activity, and the Uganda COVID-19 Response and Emergency Preparedness Project. All these partners made it possible for us to be here today. Allow me also to recognize and appreciate our keynote speakers who have taken off time to prepare the keynote addresses to share with us extensive knowledge, experience, and also encourage us in our quest for quality improvement. I would like to recognize Professor Handa Ujiro from JICA, Professor Henry Tumwine from Kavala University, School of Medicine. And this one, by the way, is my teacher. And Professor Peter Waiswa from Makerere School of Public Health. I thank you all for listening to me. It is now my honor and pleasure to declare this 10th National Health Sector Quality Improvement Conference 2023 officially open for God and my country.
Let's put our hands together again to appreciate the Honorable Minister for officially opening the conference. Honorable Minister, we have listened, and the country has listened to you attentively. Thank you for the straight talk. We need to tighten our belts because the road is getting rough and rougher each other day. Once again, thank you so much for those words of caution and guidance as the political lead of the sector. Innovations throughout the system, health system, will lead us to quality and better results. Now, Honorable Minister, we are moving on to launch the 2 documents, and then thereafter we receive our first keynote address. It will be less than 20 minutes, and it's around the same issue of health system strengthening. The keynote address will be delivered by Professor Peter Waiswa from Makerere School of Public Health. Waiswa, I'm corrected, Peter Waiswa. And the address will be around understanding health system strengthening in a resource-limited setup. And that's what Honorable Minister has just been talking about. So may I now invite the officials that will join the Honorable Minister to come and launch these 2 documents. May we have the copies ready and the markers ready for this exercise. We need the copies also ready. They're ready. So let's have WHO, USAID, Dr. Elizabeth, Dr. Jessica, JICA, chiefs of parties, or officials representing our partners, the chiefs of parties, UHA, UHSS. If you are present, please come forward. Directors of regional referral hospitals, if you are here, please come forward. DHOs, please come forward. We have Makerere University School of Public Health. Please come forward so that you be with the Honorable Minister as we launch these 2 very, very important documents. One, we shall start with survey, the report, and Professor, you can say something about the report, just a summary, because she missed the presentation in the morning.
Yes.
Yes, my teacher too.
Honorable Minister, our report found that overall general health service index in the country has increased to 59% from about 48% way back in 2018 based on the SARA finding. This is one. Two, we found that overall services availability in the country at the national level, at the regional level, in the higher level facilities, the national referral hospitals, the regional referral hospitals, the general hospitals, is as expected higher, but at the lower level facilities, the availability still remains low, as would be expected, especially in the areas of communicable diseases, immunization, and so on, where we found, in these areas, we found generally availability of services were good. Of importance, Honorable Minister, we found that readiness to provide services, especially for non-communicable diseases, cancers, remain low. This is an area that needs focus. We also found that readiness to provide emergency services, especially transportation systems, needs to be strengthened. This is what I like to report to you very briefly. Thank you.
So, Honorable Minister, we now invite you to launch the Harmonized Health Facility Assessment Report. Thank you very much. Applause. The hard copies are available, voluminous and rich. Can we have the other officials to sign this as we prepare to launch the next document, the guidelines? In the meantime, Dr. TMK, please summarize what this next document is all about.
Honorable Minister, I present the Quality of Care Implementation Guide for Reproductive Maternal Newborn Child Adolescent and Nutrition Services that was developed by Ministry of Health under SCAP leadership and reproductive health and implementing partners support. This guideline outlines the organizational structures at the Ministry of Health, at the center, and all levels of care. It outlines the leadership and governance and accountability for RAMNAC services, also at regional level, district, and community level. It also outlines the quality improvement activities that will be implemented to improve RAMNAC services, and later describes the data management systems, including the monitoring and evaluation frameworks and indicators for RAMNAC services. And finally, it describes the RAMNAC research agenda that will be used to implement RAMNAC services. So this is the guideline that we present to you for launch. Thank you so much.
Thank you very much, Dr. TMK. Honorable Minister, we now invite you to officially launch the Quality of Care Implementation Guide for RAMNAC and nutrition services in the country. you have the copies. Thank you very much. Let's now sign, continue signing. WHO, you are the mother of guidelines. Once we see your signature there, then we know that this is authentic. The cameras should get ready, because after this we take a picture and then we take our seats again to listen in to the keynote address. It will be brief. Then after the keynote, we go for coffee. Sign. USAID, sign.
So as the signing continues, I've been requested by director to inform you on how the photo shoots will be. The first shot will be the Honorable Minister, the senior management of the Ministry of Health, that's the commissioners, assistant commissioners, of course, and the director, and development partners. That will be shot number 1. Shot number 2 will be the Honorable Minister, of course, the commissioners and assistant commissioners, those are constant and development partners. Then the addition will be the IPs and those from academic institutions. So the first one has the constant, which I've said, the Honorable Minister, commissioners, assistant commissioners from MOH, and development partners. Okay, the big one, so others will stand up, and then we shall start by separating. Those of you who are vertically challenged, you just take up the podium.
We are done.
So thank you. So the ones in front can stay, of course, the Minister of Health, and then the development partners. So that's the first one. Not really. You can just put them down. Because the books are too heavy. Okay. So let's take, if the books are heavy, okay. So Alex Benson up. Very good. Of course. Director Joseph, you can stay down for obvious reasons. Vertically enhanced. Okay, the second
done with
set
that.
will include the IPs and those from academic institutions. Professor Raj? No, those you are constant. MOH, you are constant. Hey, okay, now we have the... Yes. Okay. Academic institutions, okay. From academia, please, can you join in very fast? Let's do it fast. You are key. You are very instrumental because you skill the health workforce. The cameraman, you let me know if it's not balanced. Are you done? Okay. Now we go to the other one. So the constant ones you stay. So we need now the DHOs and director of regional referral hospitals. Just to be. Of course, the last one will be the same constant with the presenters. So the DHOs and our directors of regional referral hospitals who are around, please, we like you so much because you are our frontline team members. Okay. Dr. Kware, if you go upward, our photos will be out of focus. They will be over-skewed. You just, Liya musajja wa Kabaka, so at least that's fair. DHA, Dr. Kamye, you are most welcome. Hey. So the camera crew, get that one very well. Thank you so much, the DHOs. So the constant is the last one. The DHOs and hospital directors you can get off. So now with the presenters. The presenters who are around, yeah, because you are going to enrich our conference over the 3 days. So Professor Peter Waiswa, for you will be online, you will miss out. So we shall do some Photoshop editing just to put you on, and maybe the other keynote. Please go behind, don't widen it. Just go behind. Yeah. Honorable Minister, we have a number of presenters, both oral and poster presentations. So they will find themselves, that's why the number is big. No, you just, if you want to appear in the photo, just go behind. Because it won't. So even if you stand in front of Director Joseph Okware, you want to be affected. So for you, I've decided to. No, here you are not seen from here. Yeah, the gentleman, you can do the needful. You can just squat in front. So the online presenters, you just turn on your videos thereafter, and we shall see how to merge them. Benson will appear in all the 5. Okay, the last shot. Okay, thank you so much. And over to you, Director Kware, to take us to the next.
IT. Okay, so welcome back from that session. The conference is now officially launched and opened. The 3-day QI conference is now opened. And we are ready to receive our first keynote address. I just want to make sure that the IT people here are compliant. Dr. Waiswa, or Professor Peter Waiswa, are you able to hear us?
Yes, I'm able to hear you. Can you hear me?
Very good. We want to see your face. Are you? So, Dr.
Recording in progress.
That echo. Dr. Waiswa is an associate professor of Health Policy, Planning and Management of the School of Public Health at Makerere University College of Health Sciences. His focus areas are mainly health systems, implementation research, and policy influence in reproductive health, maternal, newborn, and child health. Dr. Waiswa is a member of the WHO Quality of Care Uganda and global networks, and has led many QI innovations in the health sector in Uganda. IT professor is not able to hear us. Professor, can you now hear us? Can you hear me? Professor? The echo. Why are we getting this echo? Hello? Professor, we can hear you loud and clear.
Okay. Thank you so much for the invitation. Honorable Minister, at the USAID Health Country Representative, Jessica, and that you worked in Uganda before on SMGR, Elizabeth from WHO, development partners, directors in the ministry, DHOs, ladies and gentlemen. I apologize that I'm not with you. I'm actually in the Dar es Salaam for a meeting, and I just got this invitation to present last Thursday, which made it difficult for me to be with you. So I apologize for that, but I would have wanted to be with you there. My presentation is understanding system strengthening in resource-limited settings like Uganda. I must say, the minister, the USAID representative, and the WHO have already talked about most of the issues I'm going to talk about. I just wanted to start with what I call a key message for my presentation, and I'll come back to it at the end. That health system strengthening requires one, capacity to manage complexity. So health systems are complex, and they need to learn how to manage. And management for me is a critical word to manage complexity, to deliver integrated and good enough, minister, as I emphasize this, packages of evidence-based interventions with the target goal in mind. And the goal for the health system is actually to improve health outcomes. Now, we're talking about health systems. What is a system? A system is defined as any group of interactive, interrelated, or interdependent parts that form a complex, and the unified whole that has a specific purpose. As you can see, health systems are not just people, not just clinics, not just hospitals, not just the Ministry of Health. They are different components that must be working together in an organized way for a specific goal or purpose, which goal is to improve health outcomes. Now, this thinking about health system is actually a bit recent because the world historically has been a world of medicines, of vaccines, and hospitals. But in around 2000, in a report by WHO, which is made by the Alliance for Health Systems, the World Health Report 2000, which was health systems improving performance. This is the first time that WHO systematically started bringing the issue of health system at the fore. And over time, almost every year, WHO publishes different key documents from the Alliance for Health Systems that talk about what are health systems. The most recent, where systems thinking was defined, was 2009. And after that, we've gone through various improvements in understanding what health systems are. Now, in the report of WHO in 2007, WHO defined what are health systems. And I think it is important that all participants have a good grasp of what are health systems, because once you understand them, then you can think of how to manage them. They were defined as all organizations, people like health workers, like sweepers, like community workers, and actions like immunization, health promotion, treatment, whose primary intent is to promote, restore, or maintain health. And WHO went on to add that this must be done in a way that improves health outcomes in an equitable, responsive, and financially fair, and make the best use of resources. So the minister has talked a lot about efficiency. Efficiency is at the core of health systems. We cannot be wasteful. And she said that she's happy that we don't have much money. And I also agree. I always say the measure of a good manager is how much you have done with the resources you have, or with what you can do as a manager before you ask for more. So that is, supportive of what the minister said. We all know that health systems are actually at different levels. Primary care, which includes communities and community facilities. Secondary care, which includes most of the general hospitals. And tertiary care, which is mainly regional and also national hospitals. At all these levels, we need health systems strengthened.
Recording in progress.
I hope you can say my internet one is better to the internet stable. But like the minister has already spelled out that health systems consist of what WHO gives as Sorry, all of a sudden the internet, which has been good, has become problematic. So I was here. I hope you can see me. You can see the presentation. But we take the building blocks as the main as of now: governance, human resources, financing, service delivery, health information systems, and medical products are the building blocks. Now, typically we think that when you have inputs, money, etc., health workforce, you get outputs, and you get outcomes, and you get impact. The minister has already alluded that we increased the pay for health workers, but we don't have outcomes. Because mainly, we have done one component, which is basically improving salary, but systems are complex. systems are not linear. Systems are not linear. They are not from input, output, outcome, impact. Systems are complex. We need system thinking if we are to have the impact we need. And the WHO has defined system thinking. That system thinking is an approach to problem solving that views problems as part of a dynamic system. So, if pay is a problem, it is not enough to increase pay. System thinking involves more than a reaction to the present outcome or events. Payment is just one of the problems, but we need to go beyond it. It demands a deeper understanding of the linkages, the relationships, the interactions, and the behaviors among the elements that characterize the entire system. So we need to think beyond just one problem and how to solve that. We need to have a system thinking. And that's why WHO said that it is not a linear system. Health systems are interconnected. Look at what is in red. Health systems governance interconnects with medicines, with human resources, with the information system, with others, in order to serve the people. What happens in the spaces between the subsystems, like governance, like human resources, like financing, is important as what goes on within them, and is usually neglected. This is the core of system understanding, system thinking, and also health system strengthening. The fact that systems are complex, are interconnected. Because systems are complex, they are always self-organizing. You increase the pay of health workers, they find a way to dodge work. They are constantly changing. And then others whose salary was not increased begin to complain because they are interconnected. And getting changed becomes a problem because there is usually feedback. Because systems are complex and are interconnected. So let me give one example. And I think I'd chosen here an example of quality improvement in my presentation until the minister gave the one of payment of health workers. But let me take what the conference is about, which is quality improvement. You decide that you're going to do quality improvement. That is a governance decision, which is good. But it's not enough to say you do quality improvement and it will improve service delivery. You go straight to improving service delivery because you think maternal death is not reducing, let's go and do quality improvement without thinking about other systems. What are the information systems? Is it showing that the health workers are present? Is it showing that the commodities are there? Is it showing that the human resources are there? Is it showing that the actual quality improvement that you are focusing on is actually available? And are you looking at the people? Are the people even accessing this care? So it is not enough to have a quality improvement intervention. A lot of them are in the room. Incidentally, Honorable Minister, what we see that most quality improvement initiatives do not necessarily have quality in them or enough quality. And two, they may not lead to, a lot of the reviews show that many quality improvement initiatives don't lead to improved outcomes because of all these complexities that happens in the system, that things which need to be in place in order for QI to work. And that requires health system strengthening. So therefore, what is health system strengthening? First of all, from a policy perspective, we have the minister, we have many policymakers here. So from a policy perspective, intentionality is the process of identifying and implementing the changes in policy and practice in a country's health system so that the country can respond better to its health and health systems challenges. It starts with a policy intention and being clear on what is the policy. And I think it is very good that the minister was spelling out all those things she wants to see in the system. like a one system in terms of projects, in terms of financing. I think that is a good policy direction. But of course, policies need to be implemented. No, now at a more local level, at the implementation level, health system strengthening is defined as improving the 6 health systems building blocks and managing the interactions in ways that achieve more equitable and sustained improvements across health services and health outcomes. What this means that these building blocks and their consequences and their interactions need to be managed. The word management, I'm underlining it because I find it a critical gap within the system. Even today, we are struggling with, even me, I'm struggling with with my presentation not being on time, but also the conference being on time, because the conference management may not be an expertise of the doctors. WHO goes on to say that health system strengthening is a comprehensive, so it is not simple, it is a comprehensive and sustained. Sustained becomes quite important. Enhancement of the capabilities, the performance, and the resilience of health systems. Managing those interactions intentionally to make sure that they are well managed efficiently to produce the outcomes that we are looking for. I will give you some examples of what are some basic facts about a system that is working or that can be strengthened. And one, you know, I usually say that to have impact or to have health system strengthening, you require good coverage. How many people are we reaching? But also quality. And when we talk about quality, the issue, it is not simple, small interventions. It is a package of interventions that make a difference. There's an echo, if somebody can mute. It is a package of interventions that are important. Time was equity. If you are not reaching the poorest, then many times you are wasting resources and you cannot be efficient. So to have impact, you need coverage. Coverage alone is not enough, but also you need quality in the delivery of these interventions. Quality attends to standards, but also a package of interventions. So when the minister said, we must make a difference, deliver together, that is an integrated service delivery, which we are looking for. But also we must find a way to reach those who are left behind. In the typical models of health system strengthening, people come, there is a problem, they quickly say, oh, do this, sometimes by a boss in a health facility or elsewhere. And then they plan and implement. This kind of model cannot solve complex systems. Because there will be system bottlenecks, system barriers. We say that systems are resistant to change. You increase the pay of doctors and other health workers, and then you think, we think that we shall, because we demand pay, so they increase our salary.
Recording
and then we
stopped.
That we shall have better outcomes. But
Recording in progress.
Fails. So typical models are not linear, I said before. I'm going to use an example of a patient. And for me, health system strengthening can be compared to what doctors and nurses and others do with patients. Normally, when you have other health workers, you start by then you think, a correct diagnosis. We think that even for health system, because we demand you need to diagnose what is the
recording stopped.
And we shall have better outcomes that you are trying to focus on.
Recording in progress.
Important. If you don't have a clear understanding so typical models are not, you are not going to strengthen the health system. But also, I'm going to use an example of then a correction and
recording stopped.
System strengthening, a correct intervention with doctors and nurses. Like if
recording in progress.
Normally, when you have to give the right treatment, you start by until you have the right diagnosis, correct diagnosis. You cannot give. Even for health system strengthening, and then you need to diagnose what is sometimes changing interventions. And what is the goal that you are trying to focus on? Yes, we need to be innovative. So that's quite important. If you don't have a clear understanding, even for patients, you are doing the reviews, you are not making sure that they adhere the health system. So the way we treat what individuals and we are successful, then is what we are meant to apply.
Recording stopped.
Do a correct intervention package. Have the right
recording in progress.
And continuously innovate to make sure that this innovations are working. When you have the right diagnosis, the right intervention, and you provide it in the right package, then you'll see a dose response. And I think I want to congratulate the minister and the ministry and partners for all the improvement we've seen in the health system that have been presented today and later in the demographic surveys. Because it shows that we have improved and we can do more. So here is a framework, a simple framework that can be used when we are thinking about health system strengthening. And because of time, I'll not go into the detail, but it says what I've been saying, just like a patient. Step one, make a diagnosis. That diagnosis is with data, with consultation, is with groups, not as individuals. Number two, then based on that, you intervene. Don't intervene in complex systems when you don't have a diagnosis. What is causing the problem? Then as you do, you are constantly, you implement, but as you implement, you actually are using data to find out, is it working? And then you adjust. So just like you do your PDSAs, you can apply the PDSAs as an approach to health systems strengthening. But I think different here, you must learn to use that PDSA approach in delivering packages of interventions. So diagnosis is the starting point, continuous review. I'll give you one example, which the Ministry of Health has done with UNICEF and the Gates Foundation and others. And I think now it's actually a national planning strategy. The CODES project is where we participated. We as School of Public Health, I was the PI at Makerere and working with the ministry and the UNICEF. We started by diagnosis and going the lines. So districts, 8 districts where we started, they would come together and use data. That time they're using LHS, but now they're using DHIS2. But they need to use that DHIS2 better. And now also the DHS, the UDHS, to say how are we performing as a district, as a sub-county, as a parish. Based on that, you plan, then you implement, and you can apply quality improvement to it, and you have health system strengthening, and then reduce mortality. That was the approach. Our work was focusing on ICCM, and we already knew that for ICCM, just training without commodities, without human resource, without physical access, without utilization, without continuous utilization, you not have impact. This is called the Tanahashi model. But the point is you try to understand what are the things that we need to work on in order to make a difference. What is the current performance? What are the gaps? And based on that, you design interventions. So this was the diagnosis stage, and you go on to ask why? Why are we performing badly? And once you do so, you find solutions, and then you can apply interventions. So from problem identification to identifying the cause of the problem, and then to designing intervention. And then the management and leadership becomes critical in designing the intervention that we have identified here. But there are challenges to health system strengthening. One of them is accountability. The minister has actually alluded to this a lot, accountability in the system. Even said we should go and test for HIV and stuff like that, because that is accountability. Then most critical also, the way we use our resources is important. The issue of management, and then critically, and Honorable Minister here is the call to action, the decision space becomes important. If you are going to be designing and innovating and changing, then you should be allowed to be able to make decisions, including use of money, unfortunately, which is critical. So again, just as I summarize, systems are complex, if they are complex, they need very good leadership and management. And this is at all levels. I think my colleague, Professor Lach, presented that especially at the subnational, the health centers, etc., are not performing as well. He said as expected, but I don't think so. I think we need to improve the management and capacity at all levels. And if in the case of hospitals, beyond the director, we also need to, is the ward manager trained in management? Do they know what to do? etc. So leadership is important if you are going to manage these complex systems because they are very dynamic and we need that capacity at all levels. In terms of management, we require managers in the health system at all levels. Managers plan. So one of the critical things, we need to train people in management to manage complexity so that they can plan, they can organize to implement what they have planned, they can motivate their staff, and they can also measure, control, and see how the system is performing. So one of my call to action is to improve leadership and management at all levels of the health system. Because with good leadership and good management, when they work together in a system, you get improved management systems because there is good management. But also there is a good climate of work environment. For the health workers whose salaries were improved, we need good management system to ensure that they are present, but also a way to motivate them so that we don't use fear to make sure they perform. That will lead to a system that is more responsive and willing to cause change, and it will lead into a system strengthening, and we can have results. So as the final slide, Honourable Minister, just to say that the take-home messages are, I see Dr. Okello, I don't know whether, can I be heard?
To manage ourselves as adults. In the afternoon, there are breakaways, and if what I'm saying is not right, please let me know. The MC, I think, has the best guidance. I may mislead you. So let me invite the MC to say something about what happens after coffee. Then when do we have lunch? When do we get back here for plenary in the afternoon? Because we must finish what we set aside for today. Thank you very much. Over to MC. Please appreciate the chair for today.
Thank you so much, the session chair. Let's give him another round of applause because he has taken us through the official opening, and I think which is very good. Now, this is just administrative. We are going for coffee, and of course, I don't want to repeat his words. He said we are going to be responsible as adults. But the breakaway sessions are as follows. We have 2.
Recording stopped.
This is Ziba Hall. Then we also have Kama Hall, which is just on the other side. So when you look at your program, the Ziba Hall, which is this one, we are going to have leadership and governance. So there are a number of presentations. And of course, Dr. Mugai, he is still on the way. But in the meantime, we have somebody who has agreed to chair that session. Dr. Mary Mudiope, who is the program director of LPHS TB activity, which is a USAID funded activity, will be chairing that session from Ziba Hall. Then from Kama Hall, we have Dr. Nkoye Abdallah, who was also from LPHS Ankole region, who will be chairing that session.
Sorry about
and of course, you will introduce the presenters thereafter. And so we are going for coffee. It's just outside where you registered from. And we are going to come back after 15 minutes. Those of you, you have already made your choices which breakaway session you want to go to. And we shall take, according to, I didn't carry my Swiss watch, but according to the time check, it's 1:45. So we are going to be in those breakaway sessions since we are having a late coffee or tea break. So we shall be in those sessions up to around 1:45. That's when we shall break up for lunch. And further guidance will be provided to you in those guiding places. So our requests, we are going just to allow our guest of honor, the Honorable Minister, of course, and our dignitaries to okay, I've been guided for the tea. The ushers are going to usher you in because it's a small area and this is a big conference. So they will be ushering you in chunks. But the director, you are going to escort the Honorable Minister and of course Commissioner Emergency Health Services and our dignitaries on that table. Okay, I've been further guided that because the leadership and governance, those of you who are going to follow that track will be staying in this hall. And of course, since we are trying to catch up with the time, allow me hand over to the session chair to organize her presenters as others go for tea. Proceed to that breakaway session. So a good afternoon and just be around because your session is starting. So, Mary, you are most welcome, and we are all yours. Thank you.
Good afternoon, everyone. We have been invited for break. Good afternoon, everyone. Thank you. Mary Mdiope, the project director for the USAID Local Partner Health Services TB activity. I'll be taking through the team that is remaining here and has focus on leadership and governance as one of the key building block in the health system. We have 7 presenters. Dr. Nyeko Philbert, I think I saw him around. Is he around? Dr. Nyeko. Kindly confirm your availability. We also have Wangubo Ayub from Queen. Ayub, welcome. Naluge Prosi. Naluge Prosi, you are welcome. Do we have Lajara Betty? Welcome. And then Lucia Nakiaga. Kindly join me here.
Let us put this one a bit down.
They wanted me to start the session. Pick your card. Pick your card. Yeah, you're not the first, you're the last. No, so you're among number 3. You pick it. Those that have called out, kindly make sure that you pick your tea, your cup of tea quickly so that we can start the session.
Hospital. I'm here to present my abstract titled The Impact of Mentorship and Support Supervision to Improve Quality. support supervision and mentorship meetings and prior to the set and discuss the terms of reference, review the data and orientate the staff. The project call to the district leadership and in the brief meeting of
As a result of support supervision and mentorships, photographies improved from 88% in July 2022 to 95% in March 2023 due to handover files for mothers in active labor. We checked the results of photographs, including photographs, coaching, and mentorship. However, there was a drop in progress between April to July 2023 from 95% to 25%. When photography are positive progress is noted. Mentorships and support supervision as a ground for interaction have provided a platform for staff to share experiences, best practices, and success stories among themselves. These engagements have provided a platform for consultants and specialists to offer technical advice in their fields, expertise. Lesson learned. Regular meaningful engagements with adequate feedback becoming the effectiveness of support supervision. Conclusion. An open dialogue has improved
things are streaming wrongly. That's why there's no page.
And facilitated the creation of good practices. Recommendation. We therefore recommend that routine support supervision and mentorship should be done as per the Ministry of Health standards to achieve the intended results. Thank you very much for listening.
Hello, my name is Beatrice Nyashaba, and I am the Research Monitoring and Evaluation Manager at Adara Development Uganda. Today, I will be presenting about Adara's Hospital to Home program and how it provides continued quality of care in the community. At Adara, we believe that every woman and child deserves access to quality care no matter where they live. And for the past 25 years, we have specialized in delivering high quality health care to women, newborns, and children at health facilities, back in the community and at home. In 1998, we established a partnership with Chiwako Hospital, a non-profit mission hospital in Nakaseke District, Central Uganda, and opened the doors of the hospital's first neonatal intensive care unit in 2000. After years of continuous improvement, including investment in staff, investment in infrastructure, training and mentorship, equipment and biomedical engineering, Chiwoko is now a leading hospital in Uganda and is recognized by the Ministry of Health as a center of excellence in newborn care. Unfortunately, many countries, including Uganda, are not on track to reach the sustainable development goal for maternal and newborn mortality. Challenges such as lack of available funds for transport and other health-related expenses, lack of availability of NICU services, and lack of knowledge of when a baby requires additional care result in a number of parents not bringing their infants back for a follow-up visit. At Chiwoko Hospital, before hospital to home, only 30% of vulnerable infants came back for review at 2 weeks old. Despite being a critical time in an infant's development, because of these challenges, very few parents return for a second visit. The World Health Organization and UNICEF have documented the priority and need for follow-up programs for at-risk newborns and supporting their parents in the community. Now, to address this identified gap, Adara developed Hospital to Home, a follow-up program to support and provide quality care to small and sick newborns, both in the hospital and in the community. Hospital to Home strengthens hospital discharge processes, provides comprehensive parent education, strengthens breastfeeding practices, and promotes care that encourages healthy brain development. It also provides vigilant and home follow-up support to families for 6 months after discharge, with a developmental milestone check-up at 9 months. These follow-up visits are led by a network of highly trained community health workers. The goal of the program is to ensure that sick and small newborns, including preterms, survive and thrive. In 2019, Adara conducted a research study to evaluate the feasibility, acceptability, and effectiveness of hospital to home in the central region of Uganda. We conducted qualitative interviews with caregivers and staff prior to the study found that the program was feasible and acceptable in this setting. Qualitative results around acceptability were very strong. Community health workers were accepted and respected by the community. The community health workers loved learning about how to care for sick and small newborns. Parents felt supported and saw the community health workers as agents of hope and confidence, and community attitudes about preterms changed. Now, research from the interviews with caregivers, community health workers, and hospital staff highlighted several key themes. 1, community health workers play an integral role and are important to both parents and hospital staff. Staff expressed that it gave them peace of mind to have someone in the community to fill the critical gap by providing follow-up care to small and sick workers to continue to educate the parents at home on topics including identification of data science, immunization, child development, feeding, and referral for additional care. The study showed that the caregivers found the visits help build their confidence as they help to reduce they took in learning new skills and they put in the community health workers welcomed the training and showed that they were eager to update their knowledge and skills through periodic refresher training. The training made them health workers and the values.
The hotel is giving it.
3. Families and community members can give lives about the ability of premature parent infants survive and thrive. In Uganda, there are some cultural beliefs that premature infants cannot survive. But by involving family members, including the father and education,
when you go to Imperial, you log into the page, then you go to conference,
Thank you. Sensitization surely changed their attitudes, and the community was able to see it as surviving and thriving. Since we began the program in 2018, approximately 3,500 people in Africa and have been enrolled. We have trained and continue to support 150 workers who provide the ongoing care to families at home. During that time, we have learned the following lessons. 1. The program should be focused around family-centered care. The program focuses on engagement and education with the families, involving them in conversations regarding their baby, and encourages mothers and families to be together as much as possible. Allowing the caregivers to play a part in the care of their baby increases the baby's chance of survival. 2. Education of families must begin at the hospital to ensure parents feel confident with the basic skills to support their small and sick newborns. Following the Community Health Improvement Collaborative recommendations, it is integral that community health workers are 1. Skilled, comprehensive training that focuses on how to care for small and sick newborns, danger signs, and how to identify babies that are not meeting their development milestones and showing signs of neurodevelopmental disabilities. 2. They need support. Ongoing supervision and mentorship is provided throughout the program. 3. They need to be paid or reimbursed for any costs that are incurred. And 4. They need to be supplied with all the resources needed to do their role. Hospital at Home addresses a critical gap in the following: in follow-up care for small and sick newborns. From our experience, we recommend the following. 1. Follow-up care for high-risk newborns during their most vulnerable time should be prioritized and scaled throughout Uganda and the rest of the world. 2. We are working with the Ugandan Ministry of Health to adapt this package for a public setting and encouraging the Ministry of Health to integrate follow-up care within comprehensive community health programming. We believe that further study is needed on the scalability and efficacy of the program. And 4, finally, it is important for health systems to identify resources and referral pathways for small and sick newborns. To our knowledge, Hospital at Home is one of the first programs that have been developed specifically to support high-risk newborns in low-resource settings in their transition from hospital to their homes. It is imperative that small and sick newborns receive continued quality of care throughout their hospitalization and after being discharged home, and that parents are involved in the delivery of this care. We are proud to have a Hospital at Home package available on our online knowledge center. This package includes all the materials and instructions necessary for other facilities to implement their own Hospital at Home program. Hospital at Home program strengthens healthcare systems, and community health workers ensure that quality of care is continued into the community. The study highlighted the feasibility and acceptability of the program and showed positive impacts to both community health workers, parents, and the community and newborns. This program helps to bridge the gap between and provide continued quality of care in both the facility and the community. Thank you for listening and for the opportunity to present our work. Should you have any questions, please contact us at knowledgesharing@adaragroup.org. Hello, my name is Beatrice Nioshaba, and I am the Research Monitoring and Evaluation Manager at Adara Development Uganda. Today, I will be presenting about Adara's Hospital at Home program and how it provides continued quality of care in the community.
At Adara, we believe that every woman and child deserve access to quality care no matter where they live. And for the past 25 years, we have specialized in delivering high-quality healthcare to women, newborns, and children at health facilities, back in the community and at home. In 1998, we established a partnership with Chiwoko Hospital, a non-profit mission hospital in Nakaseke district of central Uganda, and opened the doors of the hospital's first neonatal intensive care unit in 2000. After years of continuous improvement, including investment in staff, investment in infrastructure, training and mentorship, equipment and biomedical engineering, Chiwoko is now a leading hospital in Uganda and is recognized by the Ministry of Health as a center of excellence in newborn care. Unfortunately, many countries, including Uganda, are not on track to reach the Sustainable Development Goal for maternal and newborn mortality. Challenges such as lack of available funds for transport and other health-related expenses, lack of availability of NICU services, and lack of knowledge of when a baby requires additional care result in a number of parents not bringing their infants back for a follow-up visit. At Chiwoko Hospital, before hospital at home, only 30% of vulnerable infants came back for review at 2 weeks.
And I want to call upon the presenters to be stepping forward. My name is Dr. Richard Mugahi. I'm introducing myself as the session chair, who is going to take you for this afternoon session. And I would like to invite our presenters to step forward, actually sitting on the front chairs, and then we should be starting shortly. Can we have the chief whip get people back? There are so many behind there. I had requested that they combine lunch and breakfast, but that wasn't possible because it's a quality improvement procedure. In the interest of time, I would like to request that Dr. Nyeko Philbert, Hospital Director Kabale, takes the front seats. Wangobo Ayub, DHO, also one of the presenters, step forward. Naluge Prose is already here. Thank you, Prose. Lajara Betty is not yet here. Is already here. The ladies are really QI sensitive. Amito Janet, quite packed, but if we can have the presenters in front, then I'll definitely allow them to begin. We have 1 hour for 6 presentations, 10 minutes each. So it's going to be the most important message you want us to pick and where you think the change has occurred. I have seen my friend Dr. Nyeko is already here. Those who are standing, please take your seats, or you go and stand outside, but it's okay. But I would request that we take our seats and listen to the first presenter. Dr. Nyeko Philbert is our first presenter, and he will be presenting functionalization of quality improvement structures in the region for improved health outcomes. I expect the technology to be doing the needful, and we don't have much time to spare. Dr. Nyeko Philbert, and let's step forward and make your presentation.
I see. Thank you very much. Ladies and gentlemen, good afternoon and welcome back from that tea. My name is Nyeko John Filbert, and Hospital Director Kawale. I'll take you through functionalization of quality improvement structures in the region for improved health outcomes. If that is agreeable, I proceed. That red spot at the lowest point of Uganda, left left bottom corner in red is the Kigezi region, where some 410 kilometers southwest of here. We also border DRC and Rwanda thereabout. Enlarging those districts, we are 6 districts there, composed of Kabale, where I sit, Kisoro, Robanda, Kiga, Rukunjiri, and that's the group of people we serve. The hospital is not so big. Looking at it from above, that's what you'd see. We have about 280 beds congested in a smaller area. It's not actual bed capacity. And so far, we have a 66% bed occupancy rate with an average length health facilities. These structures include the regional QI. We have the regional referral hospital QIs, the district QIs, and the health center QIs. They are abbreviated differently. The thing is not changing. Would you like to shift that slide forward? Yes, the quality improvement requires active and continued support from top leadership. We had somebody present, professor presented and told us about the role of leadership in the QI improvement. In the region, we have especially the leadership at the districts, the chairpersons, the chief administrative officers, the DHOs, the team in the regional hospital headed by the director, and each of these have a key role for us to be able to improve the quality in the region, and therefore must participate in the initiatives. In Kigezi, we have tried to build up these QI structures from health center 2s up to the regional referral hospital level. At the start, our problem was that out of the 6 districts, only 4 had active district QI committees functional. And the regional QI was not doing its role of support supervision and were not being able to perform joint review mission. We had no quarterly district national committee quality improvement assessments, and we also had limited initiative at the regional referral hospital to discuss the regional health. And therefore, we had to conform to what the national level says, that we should be holding support supervision and regional quality improvement. In the process, we had to get around those problems. As I said, they were there. The few functional district QIs, we had no support supervision, we had no joint review mission going on, and we had no quarterly district QI assessments, and so very little initiative. We had to identify
focusing on human resources for health.
QI committees.
We have 7 presenters in this session,
appointment
and
letters
we have
for the
only
regional
1
members.
hour to make sure that
Also
we
mobilize
have gone
funds
through all the
convening
presentations.
regional QI.
We want to take
committee
this
meetings,
opportunity to welcome you to this
the
section
regional
and
joint
thank you for
performance
choosing
review
human
mission.
resources for health.
We identified
I
and
think
trained
you have attached
district
the
QI
importance of
persons,
human resources for
develop
health
work plans for
in the
the regional
delivery of comprehensive
QI committees and
quality
the district QI
HIV services
committees.
and
We
TB
had
in the
quarterly
in the
assessment
country,
of
as well as
regional
other
QI
health
structures,
programs, including
and we
malaria
also went out to
and
benchmark
non-communicable
and see
diseases,
how it's done
etc.
elsewhere.
and etc.
After doing that,
We
that's what we came
are
out
going
with.
to
At the end
have
of today, as I
the
speak,
first set of
by
3
today as I
presenters
speak, we have
first,
all the
because
district
the
QI
seats here cannot
committees
accommodate all the 7 at once.
We have 90%
And then after
of the
this, we shall
regional
have the other
QI
4
committees
present after this.
functionality, as
Uh,
3.
We think that we shall have a set
And
of
then we
questions
have
after
the
the first
district,
3 presenters,
QI committee
and then another set
on
of questions
assessment being
after
conducted, at least
the next
50% of the
4
cases.
presenters. And I think we shall
All our
have
districts now
been
have
done with our session.
QI committee work plan.
Meanwhile, we are waiting for the
Ladies and
IT
gentlemen,
person to
from
fix
that
our
little
slides,
approach, we
so
can
that
see
when we
that there
start,
has been
he will
progressive
be able to
improvement
project for
in
us
the
as we follow
regional
through. Now we want to
QI
take
committee
these
assessment,
minutes to introduce
rising
ourselves
from
to the rest of the
and
team
now we are
members.
about 90.
Beginning
We
with me,
think we could do better,
I am
but
the
we also
session
have
chair.
other system
My name is
issues
Dr.
that
Nkoyo Abdallah. I work as
The
the
district
project director for
QI
USAID
assessments,
Local
QI
Partner
committee
Health
assessments
Services
also
Program
done.
in
And,
Ankole.
if you look at
That
it,
mechanism is called
carefully,
Local Partner
we are
Health
not
Services
yet
Program
there, but
Ankole and Acholi.
most
But
of
I am
us
the project
are
director
scoring
for
above
Ankole
50.
Arm.
That means we are
Ankole is
progressing,
responsible for comprehensive
During our
HIV
GRN,
and
one of
TB
the
services
biggest problem we
in
go
the 12
towards
districts
with
that make up Ankole. And those ones of you who are knowledgeable about Ankole, you will know those 12 districts. They include the mother, their grandmother, Mbarara district, and then the grandchildren of Rampara. Yes, you know Rampara is a group because so they include Mbarara, Rampara, Isinjiro, Ntungam, Bushenyi, Mitoma, Shema, Lubirizi, Ibanda, Kazo, Chiruhura, and Buhweju. Now those are the 12 districts plus 1 city that make up Ankole. So that's where I work. I'm very glad to meet you all here. I want to give an opportunity to each one of the presenters to introduce themselves as the person there fixes the slides. I think by the time they are done, he will also be ready to project the slides, and then we shall be good to go. Ladies and gentlemen, please, can you take the opportunity to introduce yourself?
Okay. Thank you very much, Chair. My name is Peter Alani. I work as the Senior Technical Advisor, Human Resources for Health, with USAID Uganda Health Activity, Lango Region. In a special way, I would like to introduce my co-author, the District Health Officer of Lira, Dr. Buchano Chen. Thank you.
Good afternoon, team. My name is Nyebembera Abia. I work as a monitoring and evaluation officer at Tasso Rukunjiri under the LSDA mechanism supported by UPMB. I'm happy to be here.
Yes, good afternoon, everyone. My name is Dr. Ivan Chemos. I was formerly working as the Infection Prevention and Control Technical Lead of Rakai Health Sciences Program, but the region has been taken over by IDI. Thank you.
Yes. I don't know whether the IT person is ready. Not yet. Can we have the other presenters also come here to... IT is ready. So, are you ready with the Alan's presentation? Alan? Okay. We are going to have 10 minutes of presentation, and then after the three of us are done, we shall have a short discussion. Then I will invite the other last 4 people to also make their presentation, and then we shall be able to go.
Thank you very much, Chair. You can go to the first page. I know the projection is not looking quite well, but we are going to manage it like that. Thank you very much, Chair. All protocol observed. My name is Peter Lani, I've already mentioned. Our presentation is on skilling the health team on the for the improvement of health workers' attendance to duty. Our case is Lira District Local Government. Next slide. Next slide. Yeah, you know, from a health system strengthening perspective, absenteeism is defined as a chronic, unexcused absence from work, which adversely affect health workers' productivity and undermine service quality. Regular attendance to duty is a contractual obligation as specified in Section F to B1 of the Uganda Public Service Standing Order. In Uganda, absenteeism of health workers in government health facilities affects health care. It's not only disruptive to proper work schedules, but increases work pressure, inefficiency, complication, and death from otherwise manageable conditions. In order to improve attendance to duty by health workers, the government of Uganda put in place an online attendance tracking tool. That is what we call the HRM10. That is run on the Ministry of Health Integrated Human Resource Information System. The online system helps districts, health facilities to generate reports, analyze attendance of health workers to inform HRH decision making. Next slide. In April to July 2023, the Ministry of Health, working in collaboration with USAID Uganda Health Activity, supported the rollout of the HRM10 to all the districts in Lango region. Lira district was inclusive. The district health team, the health facility managers, the health information assistants were equipped with the knowledge and skills on how to upload the duty roster and attendance report on what we call HRM10. Next slide. As a result of this support, the facility level attendance reporting for Lira district improved from 75% to 95%. And the DHO of Lira is here to attest to this. The absenteeism rate for Lira district reduced from 29.4% in April 2023 to 11.2% in July 2023. The healthcare workers attendance report is readily available for the senior management team in the DHO's office and in the office of the COW to inform HRH decision making. Next slide, please. So Lira district health teams, I've already told you, were equipped with skills to upload duty roster and attendance summary, as well as generating reports to inform HRH decision. This resulted into the district health officer of Lira regularly compiling and submitting to the Chief Administrative Officer a list of health workers who absented themselves for more than 15 working days without justification. Their salaries were withheld, and it would only be paid if they provide credible information for their absenteeism. Next slide. So the lessons we have learned is that updating the human resource information system regularly and accurately generates attendance data which is needed for taking feasible action in order to improve attendance of health workers. And equipping the health teams with skills results into improved operational efficiency and accurate reporting of staff attendance within the health care or within the health facilities. Next slide, please. Next slide. So these are the key recommendations. We would like to request the Ministry of Health to expedite the process of linking the Human Resource Information System to DHIS2. This will help link attendance to duty with key outputs and results. The number two, local government should disseminate the Ministry of Public Service Establishment notice on application of sanctions in case of absenteeism in public service. Our interaction with the health facility is that the health facilities are not aware of this establishment notice. The Ministry of Health and implementing partners needs to work collaboratively to support the rollout of HRM10 in whole districts and in all health facilities in the country. And the Ministry of Health, still working with partners, need to support installation of biometric machines that are linked to IRIS in all district hospitals and health center floors, if it is possible. And lastly, I would like to call upon the local governments to insist on linking salaries to attendance to duty. Thank you very much. Over to you, Chair.
IUT. Good afternoon, members. Kateba Agnes. Tasoro Konjiri. As the projection comes on, my name is Nyebembera Abia, and I'm standing in for Kateba Agnes, who is the main presenter.
Or we can get someone else.
Yes.
Agnes was not ready. The presentation is not in the file that you received. Okay. But you have one for Ivan?
Chair.
Chemos? No, the presentation is Chemos Ivan. Eh? Please, let us have that. Meanwhile, you look for the one for Agnes.
Hello. Good afternoon. So as I wait for the presentation to load, my name is Ivan Chemos. I would like to recognize my two first in their absence. Bobby Chuewa Sheila and John Bosco Muyingo that we came up with this work together. So we all know that during the peak of COVID-19,
excuse me, Ivan, since they have not been able to identify Agnes's presentation, I want to use this opportunity to invite, if Sheila is around, to join that team, such that after you, they should be able to put up Sheila's presentation. Are you okay, Sheila? Please join. What about Aston? Aston around? Please come. Come. IT, please. Sheila is here and Aston is also here. By the time Ivan is through, I think those ones will be ready. Sheila, we have Sheila Baluku. You have it. Then Aston Muchunguzi. Look for it as well. Okay, you can go on. Ivan, please.
Okay, so at the peak of COVID-19, there was a lot of need to vaccinate the population. So, and there was rollout of vaccines to the districts. So, next slide. So there was a lot of emphasis to vaccinate 5 priority groups. Those are the elderly, the people. COVID-19 vaccination. For all the facilities, there was much improvement. So we compared 3 months when we had those people, specific people that are supposed to participate in the activities of COVID-19 vaccination, and then we also compared to 3 months when we didn't have these people that are specifically supposed to carry out COVID-19 vaccination activities. You can see, for example, this first facility, there was a very huge improvement because this health worker was so dedicated and would do all the activities that we had requested. Next slide. So there was a, you can see that over 1,071 1,171 clients were vaccinated in the period of 3 months in that one facility alone. So there was a lot of improvement. Same to the other facilities, just that I didn't put the figures here, but there were a lot of improvement. Next slide. So what does this mean? Increasing, if you want to increase vaccination rates at the facilities, you need to have dignified or designated health workers that are solely responsible for COVID-19 vaccination. Next slide. So what we have learned is that in case of future outbreaks, in case we want to have campaigns, in case we want to have things done in a faster way, it's better that we have health workers that are responsible for that activity, not only in COVID-19 vaccination, even in other immunization programs, even in other activities and facilities, we need to have such that they are tasked, they are held responsible in case the numbers are not numbers. So that's the end of my presentation. Thank you so much for listening.
We have now Sheila going to present because the other presentation is lost in the system. So if Sheila, you are ready, please come and make your presentation. Please note down what you are going to ask and what you want to share with the team. I think in the next 5 minutes or 10, we shall be able to discuss the first 3 presentations, and then we shall have to load the last 4, and then we shall end the session. Sheila, please.
Who is loading?
We are waiting for Sheila Baluku's presentation. Sheila Baluka, yes, please.
Good afternoon, everyone. My name is Sheila Baluka. I'm a biostatistician in Jinja District Local Government. I'm here to present to us an abstract on empowering DHMTs to counter health workforce performance challenges, a case study of Jinja District. So as an introduction, we have seen various studies focusing on performance challenges, and we have seen these affect the health system performance in regard to attainment of health system improvements or innovations. So Makerere University School of Public Health and Ministry of Health supported Jinja District to implement the Management Strengthening Intervention, the MSI. So this MSI is based on an action research, and where teams analyze their problems related to health workforce performance. They develop appropriate work plans, implement these work plans, and then observe as they learn from the implementation. So we are sharing how Jinja District implemented this intervention. So there was an orientation visit that was organized to acquaint the team with the intervention. We did a situation analysis to see where we were at that particular time. And the major performance gaps that were identified were ranked and prioritized. And low coverage of immunization by 1 year, low coverage of fully immunized children by 1 year, ranked number 1, and the intervention was aimed at improving this coverage. We did problem analysis using the problem tree, and some of the root causes that came out were poor planning at the DHO's office to support the immunization activities. Then there was also inadequate supportive supervision at health facility level and limited community engagement in immunization activities. We had an operational work plan and then disseminated it to the district leadership for approval. We set performance targets for the key staff that were involved in this intervention, and these were mainly the community health work, the health educators, health assistants, and the cold chain assistants. We monitored implementation through supervision and holding periodic meetings to review progress. We also had a diary introduced to capture reflections and learnings from the implementation, which lasted for 8 months. There was no major funding, but we had facilitation for the workshops and that we held. So these results. These are the results. The results we managed to accrue. We had 18 items on our work plan, and we managed to implement 13 of them. The health facilities, all the health facilities that conduct immunization were able to submit complete reports on immunization, and 85% of these, that is 56 of them, had their EPI micro plans finalized and submitted. We monitored the processes using a journal on submission of complete reports on immunization, and we managed to register improvement from 67% in financial year 1920 to 82% in financial year 2020-2021. 87 was a typo. So that is how the performance. We did this at the height of the pandemic, the COVID-19 pandemic, and that is how we fared during the implementation. And then post-implementation, we see we were affected. We were doing quite well, but the performance dwindled because of the introduction of smart paper technology, which was specifically introduced in immunization. So it affected us, and as you can see, that drop was due to complete reliance on the technology. So the performance was quite low, which technology has now been halted by Ministry of Health until further notice. So the improvement registered in the coverage of fully immunized children highlights the overarching benefits of this intervention. And we also see that health workforce performance challenges encountered have a direct bearing on the health system performance, and when addressed, we can achieve great impact. So we also learned that deeper analysis of the problem to ascertain the root cause created a sense of ownership among the members, and also documentation along the way encouraged knowledge sharing, and also fostering replication of best practices. Realized that the problem tree, it was not fine. We kept adjusting it along. So in conclusion, when you address a problem from a root cause, it yields better results as opposed to finding solutions haphazardly without a deeper analysis. And then we also realized that financial resources alone do not drive an intervention to success, but rather an inspired human resource. So an application of this MSI in handling performance challenges can have far-reaching benefits. Thank you for listening.
Thank you. Thank you, presenters, for being brief and on time. Now we want to use this opportunity to ask these colleagues of ours a few questions. We are going to take like 4. Since there are 3, we'll get maximum 6, 2 per person, and then after that we have another set of 4, and then we go through. Please, who is going to help me? Okay, let me, okay.
I'll do it here. Start from here? Okay.
Thank you so much, Chair, for your able guidance of this session. I'm Dr. Uma, and I'm a patient safety consultant. And my question is going to my brother from Lira. I forget your name, but your presentation was very interesting. And I noted your innovation is a wonderful innovation, but I feel like it's a step away to being very expensive with lawsuits. So you mentioned that 15 staff after your implementation were sanctioned. And my question is, what measures had you put in place before the sanctions to ensure that they improve their performance or their presence before you levied the sanction? And what legal framework were you acting upon? Because we have the public standing orders and all that kind of stuff. And I would like to know maybe what innovations you had put in place to first improve their performance and maybe see that they were not coming through. And then you gave them sanctions by withholding salary, which is something that is a step away to a lawsuit. Thank you.
Yeah, thank you so much, Chair, and thank you so much, presenters. My comments go to the first presenter, that is Alan. Number 1 is what were the root causes of staff absenteeism in Lira? Number 2, how do you compare staff attendance with productivity? And how did you rule out processes of people coming, you know, their attendance, or they sign, but they don't reflect on the work? Then to Chemos, the surge staff, how did you manage the sustainability part of these staff? Have you absorbed them into the national system or structure, or what is happening? Thank you.
Yes, so thank you very much, presenters. I have, my question goes to Chemos. You said that the government spent a lot of money on the surge, and then we got a cheaper option. I would have loved to see a comparison of the costs between the time of the surge of the government and then the time we had those health workers put in place. So you could speak through it and tell us how the difference in the cost was. Is it manageable? And the other thing is that we saw Matete Health Center 3 doing so well. The others were actually not doing so well, to be honest. What is it? What was unique about that individual? Was it a staff at that health center that you employed? Was it someone you brought from out that had better social behavior change communication skills to make this better? We need to know what happened exactly, probably. It will help us pick some knowledge. Thank you.
Okay. Thank you. Thank you. Thank you very much, ladies and gentlemen, for those questions. I want to give the opportunity to my colleagues to answer. Maybe I can also ask Sheila. Sheila, when I was looking at your graphs, I saw both the pre and then the post during implementation processes. There are several surges, downfalls. I don't know what the reasons were, because the text boxes were not readable. You couldn't understand exactly what was causing the downfalls in performance for both pre and also during the intervention. So, Alan, you want to come first?
Thank you very much, Chair. I will start with what were the root causes of staff absenteeism. We worked with the DHT to conduct a deep dive on what was causing absenteeism in Lira district, and we found two major factors. One was the poor supervision at the facility level, because the health facility in charges were also absenting themselves at the same time with the people that they supervise. So they could not carry the whip on the people that they supervise. Then two, there was no consequences. You absent yourself, you go to the bank at the end of the month normally. So it became almost a routine. Those were the two root causes that we identified, but the DH of Lira is here to add on. Then what mechanism did we put in place to ensure that the people that are coming for duty is attending and actually working? We have built the capacity of the health facility in charges on how to conduct internal support supervision. If you go to the health facilities, you find that the health facility in charge comes and sits in his office. It does not monitor what other health workers are doing on a daily, on a weekly, and on a monthly basis. So we have encouraged them to strengthen internal support supervision to ensure that when the health workers come, they register into the attendance book. They actually attend to their duties and performing their key mandates. And that can only be strengthened through conducting internal support supervision. DHO, I don't know whether you can respond to what innovation did you put in place before you sanction the 15 or so health workers that were absenting themselves on a regular basis. One can share a microphone with you.
Let us deliver the microphone to the DHO. He's here.
Yeah, thank you. What is very clear is that all that we are doing as far as tracking attendance to duty is also informed by the Uganda Public Service Standing Order 2021. And so in that Public Service Standing Order, it is very clear that any staff who absents himself or herself from duty for 15 working days without any clear reason must forfeit salary for that month. It is very clear. So what actually we did was that first was to begin implementing this. And one of the in-charges of Health Center 3, that was I think Agali Health Center 3, reported that by doing this, what we're doing, withholding salary, it has made their work very easy. These days, they don't need to be following their staff, calling them, why are you absent? Because they know at the end of the month, if they absent themselves, they will not get salaries. So managing their staff became so easy. But also another thing we did was that all those ones who had who were absent and whose salaries were withheld, we all called them. And the chief executive was there, their chairperson, Lira District Service Commission was there, and I was there myself. And we took them through key issues about public service, especially attendance to duty and unofficial and official leave. Many of them came to know that we were actually acting very rightly, but initially they didn't know anything about this. So we also came to know that Public Service Standing Order is a tool that is being used, but unfortunately the duty bearers and even the health facility staff, many of them are not aware of this very important document. So actually they went back realizing that they were at fault, and they also went back as messengers to tell others about these standing orders. We actually learned that we need to disseminate these, especially key issues about public service standing orders, to all the employees, because some of them absent themselves without knowing. Yes, it is true that Lira is implementing what human capital management payment system. Partly, some of them were absenting themselves, excusing themselves that they are not being paid salaries. But when we withheld salaries, that was when they now came Because each time you go to ask, why is this one absent? He's saying that last month he or she did not receive salary. And then yet actually they received. So it was only when we started withholding salaries that some of them started coming up. There were also those who were on unofficial study leave. They were for studies. And so when we started withholding their salaries, they came up because there are many. There are more than 200 staff, but a number of them came up and we got to know that, yes, there were some who were absenting themselves because they had personal reasons that were actually not linked to the rules and procedures of the local government. I think that's my submission. Thank you.
Thank you, DHO. That was a good explanation about the issue. Ladies and gentlemen, I want you to note that the issue of getting onto the is it the foreheads or the head of the individuals who don't want to work can work, because I've also seen it in Ankole. In Ankole, we are implementing a mixture of two. We have some districts where it is purely district-led programming, but also have some districts where it is a mixture of district-led and also IP-led. But in those districts where it is purely district-led programming, this method has worked. I want to give you an example of Chiruhura district. And the DHO is here. I don't know whether Dr. Kamya attended this session. I think he has chosen to attend the other because he has mastered human resource management. In Chiruhura, if a health worker misses work for those number of days, the DHO will recommend him or her to be scrapped of that month's salary. And the health workers have heeded to that. Now they are working. And you know, last year Chiruhura emerged the first on the ridge table. And to receive an award here in my presence. Those health workers have learned, actually, some of them have run up to us. You know, Dr. Nkoyo, you are the one who is in good talking terms. Dr. Kamya, please talk to him this time. I am very sorry. I will work. Let him not take me off. They have come to me, and I've even pleaded for some of them that this man is on his knees. So let us forgive him, then I think he will not do it again. And the people have changed and they are working. So let us pick this lesson from here. Let us talk to our DHOs to pick it and use it, because services are crumbling in the districts where we work because of absenteeism. Now, what we have resorted to do us as IPs, where we find health workers are not working and it is not district-led programming, we employ. I think you are also doing the same. We employ locums, we employ stand-ins, we employ volunteers, every category. We have so many categories of employees there in the district, but because of the absenteeism. But in those districts where it is led by the DHO, there is nothing like that. And things are moving. Now, we are spending less money in the district-led programming districts than in the district mixed programming districts. Because there, the DHO instructs all is, you just inform the DHO that, you know what, our targets are like this. We need to ensure that we put this one together, this one open. Then he instructs the team. Then you are spending less money. You're only spending on processes. But these other districts, we are spending money for employment. We employ extra people. We pay extra monies for a single activity, because people say we are not going to do that TASO's activity. Those are TASO things. They even they don't know that these are means of health activities. They think it is an IP's instruction. So I think we need to take that direction, and we want to thank Alila for that innovation and being able to demonstrate that things can work. Thank you. Let us go to, are you ready? Please, did you have any question?
Yeah, I had.
Please do go, and let's Sheila complete, and then we have another set of 4.
Okay, thank you so much. Sorry, I didn't get the name, but you talked about sustainability of this such stuff. So here we are working with the DHO and the facility in charge. Even during recruitment, they know that these people are going to be here for a short term, and we are showing the facility that if you have someone that has been put specifically for this work, if you have someone that has been, if you have maybe 4 staff in MCH, you can put aside one that's specifically tagged for this work, such that after these such staff are out of payroll, they can, the normal routine work can still continue. So we looked at the results even after we removed the such staff, because we picked the results before we recruited, and then we also picked the results during when they were working, and then we also looked at the results when they had worked. Just that I didn't put it in the presentation, but we saw that there was some improvement. There was still an improvement. It didn't go back to when it was before recruitment. So it was just the facility to learn that we can have improvement when we have someone that's specifically tagged for this work. And then someone also asked about the difference in the cost. So here, in the government type of mobilization, the government goes to the community and mobilizes, moves in the different parts of the community to mobilize. So in moving to the different parts of the community, you're putting in a lot of money. But here we are saying that we are using the opportunity that people have gathered. People always come to the facility. So we don't want someone to go back when he's not vaccinated against COVID, when you have come to the facility where we have the vaccine. So we don't put in money to mobilize people, but we're just using the opportunity. Even in marketplaces, people have gone to the market and they're already there, so we talk to them, health educate them, and they come and get vaccinated against COVID-19. So, and then you also asked about the Matete, what's unique about the Matete Health Center 3. One is that I realized that this staff was part of the staff of Matete Health Center 3 before recruitment. She was already volunteering there, and the fact that she knew the place well, I think, and she was also dedicated to her work. So I think that's all the questions that I had. Thank you so much.
Please, Sheila, we want 1 minute, Sheila.
The major occurrences that affected performance in the implementation phase, we had the Child Health Days. We used that platform to improve our performance. And then the general elections, of course, we saw that, and then we anticipated challenges, so intensive mobilization was done, and performance was not affected. Then the nationwide lockdown affected our performance negatively. It fell. We didn't have any control over that. So as soon as the lockdown was lifted, we got back on our feet and were above the target. But as soon as we got back on our feet, Ministry of Health listed our district as one of the districts that were scaling up smart paper technology, a purely digital solution. It was new to the health workers, and that also affected performance. But we tried to be ingenious to use it alongside the paper-based. That is how we try to sustain. And then they told us to take our hands off the system, purely smart paper technology. So the sharp fall in the graph.
Okay, thank you very much, ladies and gentlemen. Please join me to applaud Alani, Sheila, and Ivan for this presentation. Please, thank you very much. I would like to request you to keep your seats, and then we resume. So, can we have Muchunguzi? I saw you were around. Please come. Aston, Tom, and Nasa. Aston, Tom, and Nasa. Did you clear? It is there now. The other presentation. It is now.
Yes.
Aston? Tom. Where is Aston? Where is your Aston? Yes. Please. Take my seat. Okay. Who is ready to start? I'm ready. Okay, please. Is that next presentation ready? It is here. Tom is
Yes.
here. And Tom, you have been naturally selected. Thank you.
Thank you, Chair. Dear colleagues, I am called Tandiswar Tom Bategeka. I work as MRO of Ndugi Hospital and at the same time the President of the Medical Records and Health Informatics Professionals of Uganda. I have my co-presenter who is on right called Manenga Emmanuel, is in Arua. So I was given to write on a theme of health information management, which is my area, and here is the presentation. So health information management in Uganda health system involves collection, storage, analysis, and dissemination of health-related data and information, and it is essential for effective planning, monitoring, and evaluation of the health programs, policies in the country. And some aspects of this health information management are as follows. Correction and reporting. Health information, excuse me a bit, I think there's a mix-up somewhere. There's a presentation which is sponsored by Pathfinder Activity. I want the one to present it, not this one. Sorry about that. Check there are two presentations there you have. Present the one which has family planning activity. The next one, yes. The next one, that one, yeah. Yes. Let's proceed. So, as you can see, Bomeka is an association which is uniting the health informatics and medical records professionals of this country. But as a young association, we have been sponsored by Pathfinder, you got a family planning activity. And that's why I am here. IT. Can you proceed? Is this the one I'm talking about? Okay. It is not this one. Because the first one is data collection and reporting. It's not this one, my brother. I want the one which is sponsored by Pathfinder, my presentation, not this one. Yes. No, there were two. Just get that one. The next, yes, that one. The next, no, not that one. The one which is second, yeah, that one, yes. So can you project it? Sorry about that. This is all about issues of IT. Thank you. Yes. So one of the aspects, you have data collection, where health information is collected at various levels, starting from health facilities, and at the grassroots level to the district national level, data is collected on various aspects, such as patient demographics, diseases, treatment outcomes, and resource utilization. Second aspect, we have the health information systems. Uganda has implemented several information systems to manage and store health data. The district health information systems, DHI2, is widely used as a data collection and reporting at the district level, and the system has to consolidate information at various facilities and provide real time for decision making. It is not moving. So we have data analysis and reporting. Once the data is collected, it is analyzed and reported at different levels within the health system. This helps in identifying health trends, disease outbreaks, and that intervention. Reports are generated to inform policymakers with managers and other stakeholders about the health of the country. Then we have health information exchange, where there has been need for sharing health information between different levels of the health system. This includes the exchange of data between the health facilities, district health officers, and ministers of health to facilitate and coordination, collaboration, and then informed decision making across all levels. We have capacity building, where Uganda has invested in capacity building programs to train health workers on health information management, and this includes the training of data collection, analysis, reporting, and the use of health information systems. This ensures that health workers are equipped with necessary skills to effectively manage information. So here I just gave an example of how that is analyzed and is shared in terms of performance, where green represents the best performance, red, that's the poor performance, and yellow, it is somehow reaching achieving the target. So generally, in conclusion, overall information management in Uganda is essential for improving the quality of healthcare services, resource allocation, evidence-based decision making, and helps in addressing all challenges tracking towards health goals and ensuring the efficient resources in the health system, and has been the essential tool in improving efficiency and accessibility of healthcare in the country. For God and my country. Thank you very much.
Thank you, Tom. Please, who is next? Please, go ahead, Agnes.
Those guys have confused me. Have this.
All right.
I've been disappointed, actually.
Thank you, Chair. Our abstract title is Integration of Services to Ensure Productivity of the Available Health Workers, a case of Tasso Rukunjiri Center of Excellence. So allow me to recognize the following. That is the co-authors, that is Agnes Kateva, that is our Center Program Manager, Sari Johnston, our MSTL, and Agaba Felix, with whom that we came up with this presentation. Then affiliation, Tasso Uganda and the Uganda Protestant Medical Bureau, UPMB, our IP. Introduction, Tasso Rukunjiri is basically PNFP, which was started in 2004 to deliver TB and HIV services to the community. Then in the program year, October 2021 to September 2022, the facility had 25 contractual staff and serving a total clientele of 7,075. In the program year, October 2022 to September 2023, the number of contractual staff was reduced from 25 to 17 due to budget constraints. So despite the reduced number of staff, HIV testing services targets increased now from 3,500 to 16,038 vis-a-vis the reduced number of staff. So a review of these increased targets versus the reduced number of staff prompted management to set new strategies on how to achieve the targets, with integration of services being at the forefront. Methodology, how do we do it? So as the team moves out to do these other services, like artery refills, TB contact tracing, viral bleeding, VMMC, that is voluntary medical male circumcision, and other services, it has to incorporate in HTS services so as to come up with the big numbers, the big target. So in pictorial 1, you can see this is a group sessioning for the construction workers. Then in pictorial 3, this is a medical worker, a counselor conducting pre-test counseling to the VMMC volunteers, so to make sure that they are screened for HIV testing before circumcision. Then in pictorial 3, that is a counselor. The primary role was to do contact tracing, but of course she had to go with the HIV testing kits to do HIV testing before continuing. Then these are the results. So we are seeing that despite the reduced number of staff from 25 to 17, HIV testing services significantly increased from 3,544 in the other program year to 9,114 in the program year October 2022 to September 2023. So with an observed gradual increase in positive cases, the positive cases for the other previous year was 164, and the current positives were 210 vis-a-vis the reduced number of staff. So this graph basically just summarizes the results up there. Then this is a graph which is basically looking at the entry points for HTS index. So in a nutshell, I'm trying to compare out of the HTS that we did, 94% of the HTS in this current year, it came from the community. So meaning that we needed to have moved out in order to achieve this target. But how? With the limited resources, integration of services. Then this is just a graph showing the systematic improvement by quarter. So you can see that October, December, we had challenges, and we normally attribute these ones to our IP, because that is basically a budget quarter. So we are still coming up with the budgets that we haven't received the funds to go out to do the activities. But once we receive the funds, you can see the graph from January to March. The graph is, it's a positive trend. So discussion. So discussion, there are missed opportunities for HIV case identification at community level, which never feed into the existing LSA systems. And this is due to limited resources. So we are saying integration of services is a cost-effective strategy which is supporting TASO Rukunjiri to achieve its set targets in most of the indicators, given the limited resource envelope. So some of the lessons learned is that prior involvement of the CASAs are community health support agencies, so which you can term as community health workers for the health facilities in the government. So it is important in demand creation of HIV testing through focused mobilization. They do the mobilization and we do the testing. Then we're also saying that a key stakeholder partnership is fundamental in providing a holistic package of HIV services. This basically involves good collaboration with our IP to make sure that we have the materials. Then to achieve quality of care by the service provider, for us we are saying emphasis should not be on the number of staff, but rather a team of health workers that is well empowered, equipped, and result-oriented. Then in conclusion, we are saying integration of services is effective in human resource limited settings and is instrumental in achieving the UNAIDS 95 targets by 2030. I thank you.
Okay. Thank you. Thank you very much, Chair of the session. My name is Kasad Nasa. I'm here on behalf of Hope Missionary Hospital, Tololo, and Makerere University School of Public Health. In their absence, allow me acknowledge my co-authors, and that is Senior Professor Peter Waiswa and Dr. Ruth Namazi for helping me put up this work I'm going to present today. Ladies and gentlemen, I would like to invite you to share with me a deep dive into sickle cell disease in the country. Tonight, I'm presenting the second leading cause of admission of children in our healthcare facilities in most of the regions of the country. It is one of the neglected diseases. That's why we don't see numbers coming in through the Ministry of Health database. Okay, so this is our simple outline. We shall go through a brief introduction and the methods, results, discussion, lessons learned, conclusion, and recommendations. Let me just introduce this topic. It is impact of empowered religious, political, and influential personnel, and we are doing this through a community-based approach to reduce the burden of sickle cell disease in Uganda. So this approach is not to treat, but to reduce the burden. Because if we go back to our first presentations, the minister talked about the burden of blood in the country and how people are hesitant in donating blood. Ladies and gentlemen, a sickle cell disease patient to survive in a year needs at least 130 people to donate their blood for them to survive in a year. So that is quite expensive. All of us here, we are hesitant to donate blood. So the moment we don't donate, these children are going to die. Okay, so sickle cell disease is the most neglected global health problem with about 8 million people affected. And the number of newborns with sickle cell is projected to reach 404,200 by year 2050. And 95% of children with sickle cell anemia, these ones occur in low and mid-income countries, Uganda inclusive. And 90% of these children die before the age of 5. So we have greater than 500 sickle cell anemia children dying daily due to poor management. When we mention such a statement, I know you really understand what takes place within the facilities, how these mothers and children grow up to find blood, okay? And even how health facilities struggle to get blood for these children. So in Uganda, about 20,000 babies are born with sickle cell disease. And this is just the small number which is reported. Very few people are doing sickle cell screening within our facilities. So this number is looking to be big, but in actual sense it may be small because we don't have capacities to do newborn sickle cell screening. And 30% of these children in Uganda die every day due to poor management, failure to find blood, and the expensive nature of management. And unfortunately, the biggest burden of sickle cell disease is in families living below the poverty line. And we have hydroxyurea, which is currently the mainstay medicine, but it's not affordable because the pill goes at a minimum of 500 to 600 shillings per pill. But remember, these children are supposed to take these pills every day and for life. So this kind of management is not affordable within our setting. And given that sickle cell appears in children within families living below the poverty line who cannot even find food, it is quite challenging to access and afford such medicines. Okay, so here I'm showing you what we are trying to implement. On my left, there is a picture when we are engaging religious leaders. This is a reverend within Tololo district where we had visited them to enlighten them on the power of empowering religious leaders to educate younger couples and all the mass within their congregation to take and make informed decisions before they take on marriage, which may result into a disaster. On the left is a sickle cell disease child who is receiving blood, and a helpless mother seated on the ground, with less hope left for her child during that transfusion session. So the methods, what are we proposing? So we are saying to address this challenge, we propose an innovative community-based approach that involves raising sickle cell disease awareness within our communities. And we want to do this through empowering religious leaders, political, influential leaders, and VHTs. These people are available everywhere. Every village has at least a church. It can be even a church under a mango tree, but there is a church. VHTs, currently we have VHTs at every village. And in every community there is an influential personnel. In our first presentation, we saw how government is struggling with human resource. You know, everyone who is trained and you want to take them to the villages, you know, to raise awareness, they will need per diems, they will need fuel, you know, they will need good vehicles to reach, you know, those hard to reach areas. But we are saying, look, we can have influential personnel within these communities, there are religious leaders there, there are even VHTs there. We can use these people who are readily available, you know, through cheaper means to have them deliver awareness messages to our community. So through their reach and influence, they will disseminate one, sickle cell disease prevention and control messages. And number two, emphasize the need for genetic testing and counseling before marriage. Because, you know, if you two people are not carriers, there is no way you will produce a sickle cell anemic child, you know. If one of you is not a sickler, you're a sickler, and then you also marrying a carrier, you know, those are going to result in two disastrous conditions within your family. Okay. So these are some of the tested results. So we say only people with sickle cell anemia and carrier couples can give birth to children with sickle cell anemia. And then we are saying hydroxyurea and bone marrow transplant is for already affected children and highly expensive and has no role in reducing the burden of this disease within our country. So there is a proposed cell-based gene therapy, which is currently approved, but it's for children who are 12 years or older. And I need to draw your attention that most children with sickle cell anemia, greater than 80%, die before the age of 5, and 43.3% die by age 10. So you bring out an intervention which is targeting children who are above, 12 years of age. In Uganda, you may not find some. You may find very few of them. So this intervention cannot be, sustainable and manageable within our country. In our discussions, these are very few points. So the number of children with sickle cell anemia in Uganda is high, and this is similar in most of our sub-Saharan countries. In Uganda, there is currently no affordable treatment or cure for sickle cell anemia. So primary prevention becomes the most effective, efficient, and cost-effective approach. And lessons from similar approaches in preventing other genetic disorders support the viability and feasibility of the proposed strategy. So let me take you through the recommendations, and we can have this and then. So in the conclusions and recommendations, to achieve the United Nations Sustainable Development Goal 3.1, 3.2, 3.4, and the National Development Plan 3 target of reducing infant mortality rate from 41 to 34, and under 5 mortality from 62.2 to 30 by 2025, sickle cell disease has to be clearly programmed with clear sustainable approaches and realistic goals. So through the empowerment of this personnel, we project a reduction of up to 90% prevalence of sickle cell disease within our country. And implementing this community-based approach, which utilizes familiar faces for spiritual healing, marriage, and death ceremonies, provides a very sustainable and cost-effective way of combating this epidemic. This will reduce the morbidity burden onto our healthcare systems and lead to more investment and foster development. Therefore, we call upon Minister of Health and partners to support us in implementing this approach. Thank you very much.
Protocols observed. Good afternoon. Ladies and gentlemen, allow me to present to you the second presentation. Yes. I'm Dr. Aston Muchunguzi, a public health specialist from Beira Foundation, Uganda, Hoima region, and I'll be presenting to you my abstract on improving access to cervical cancer screening among women living with HIV. And this is through reorganization of schedules of human resources for health in Chikove district. And I will recognize my co-authors, Dr. Andrew Ndaura, Glorious Nyamukiza, who is the HIV focal person in Chikove district, Dr. Betty Nsanji, Dr. Dennis Birunja, and Dr. Dithan Chiraga. it is paused. Maybe you can share again. The screen sharing is paused. Maybe you can stop share and then. Okay, thank you so much. So we know that women living with HIV stand 6 times the risk of acquiring cervical cancer, and the Ministry of Health recommends that we screen these women at least once every 3 years. So we looked at 13 rural health care facilities in Chikove districts and realized that as per the target we had given them, by mid-January 2023, they had screened only 9 out of expected 24 women living with HIV. So as we tried to review their data, realized that some of the reasons that were causing this were related to low staffing levels, as the few staffs had to serve in other units, that is maternity and EMTCT clinics. They also had capacity gaps, and they lacked a system to identify who is eligible for screening. So together we developed a project, that is a QI project, that was to improve cervical cancer screening uptake from 37% at that time to 100% within 3 months. So this is the methodology. As said earlier, we implemented it at 13 rural healthcare facilities, Center 3s, and the officers from Beira worked with the midwives and the staffs plus the peer mothers at the different facilities and used the 5 whys approach to identify the reasons related to this suboptimal performance. And I've already highlighted the root causes earlier. So we use the electronic medical records to line list these eligible women who are due for appointment and also pending cervical cancer screening. And the role of the peer mothers was to call these mothers to remind them that on top of coming for care, we shall be subjecting you to cervical cancer screening. So we worked with the district health leadership. The HIV focal person was vital in this, to schedule the midwives from the facilities that are well-staffed to come and support the rural health care facilities with screening and also providing on-site mentorship. And we are monitoring our outputs through the peers, the PEPFAR in-country reporting system, and the midwives that were performing suboptimally would reach them weekly through a phone call and see how they can improve their performance. So figure 1 is showing the interventions that we implemented where we line listed. This was to cross the other gap, to have a system that is line listing all people who are eligible for screening. And then we send reminders, and then we had off-duty midwives from other facilities supporting and mentoring the on-site midwives. And as you can see, by week 2, that's where we started. Week 3, we started implementing and you see how we improved the uptake of cervical cancer screening at those health center 3s. And that surge included the number of women who were called earlier, they missed opportunities to come and use that opportunity to also screen. After week 9, we had to scale down for sustainability, and we appreciate the fact that even after leaving the health center 3s to support themselves, they were able to continue achieving above the target of 12 women per week. So lessons learned, that systematic approaches to identifying eligible women, like line listing, like we did, can improve screening rates. Use of mentor midwives to improve the capacity of other midwives, and also district leadership involvement in special services, like the one I'm talking about, can increase their uptake in health facilities. So, in conclusion, in the context of low staffing levels, as you're all aware that we are not scoring well, utilization of leave-off days for staff to reach targeted populations improves access to special health services, like this one specifically. My recommendations, or our recommendations, are: one, can we explore the possibility of task shifting certain aspects of cervical cancer screening? We know that some of these methods of screening, if we can train some community health workers and also some nurses instead of focusing on midwives, can alleviate some burden on midwives and improve accessibility. And as per the abstract, if we involve district or city health teams in decisions, can improve NCD screening, integration, and management. Thank you so much.
Let us have a few questions because we are standing in our lunch. We are just between
Thank you.
ourselves and lunch.
Yeah, thank you, Chair. So, just for the last presenter, the title of his abstract was talking about reorganizing work schedules for health workers, and then he was talking about using mentor midwives who are off duty. I don't know whether off duty you meant leave, and if it is leave, these are mentor midwives. I am just imagining, were they providing the screening or they were mentoring? If it is so, how does it then contribute to the increase in the screening for cervical cancer? Because I expected the gap to be service provision, not mentorship, not capacity a problem, not a knowledge gap. So if you get a mentor midwife who is off duty at her parent facility and you bring them here to mentor, are you bridging the service gap? And I'm just wondering, I would like to seek some clarification. Thank you.
Chair, I think I was moving next. Mine is to Kasada, and thank you so much to all the presenters. I wanted to understand, Kasada, how you were in position to measure the impact that is caused by the religious leaders' messages. As we empower them, how do we know that this is the actual number that is getting this service, and how is that attributable to the sickle cell management process at the facilities? Number two is to the first presenter. Of all the indicators that you showed, what was sustained by the health management systems? I missed that indicator that was actually sustained. Maybe you could throw more light about that. Thank you.
Okay. Who wants to ask? Yes.
Thank you, Chair. To you, Abia. We saw a very exponential rise in the number of persons tested. I don't know if we adhered to the eligibility screening tool, because Minister has been talking about wastage within our health system, to at least test the persons who are eligible to be tested for HIV. And then also related to burnout, did we have quality maintained in the testing processes? Thank you.
Yes. Can I go? Please go. Thank you, presenters. To the first presenter, my question is regarding using the health records. I wanted just to tell us some of the hiccups that you found in managing data at facility level, because many times our challenge is doing so much and writing nothing. And therefore, using that strategy, how are we able, what were the real challenges, and you close them so that we can now be able to score a green or red. To Kasada, my question is related to what Juko was asking, actually. My ask is regarding the mobilization, how impactful are the religious leaders and the influential persons in ensuring that we have community systems referring, like I wanted you to talk about the referral systems from the community to facility. How do you vet that? Community facility referral systems for the sickle cell anemia clients. Thank you.
Yes, and then we have our last question from him.
Thank you very much, presenters. My question goes to the last presenter, that is Aston. How did you motivate these health workers to give support, and to what extent? I mean, the funds, if funds per diem, how much? Thank you.
Okay, now let us have these answers done from the right, and then will be the last. You have the microphone.
Okay, thank you so much. I'll start with the first question. So to answer the first question, I think I would simply summarize my abstract. Facilities that are underperforming, and you do a root cause analysis, and as mentioned earlier, you find the problem is related to staffing, having one person serving in many clinics. It also has challenges related to capacity. And what I was presenting specifically is how do you get the mentor midwives? The midwives are already trained from better staffed facilities to come and support lower healthcare facilities to solve all the root causes, as I've said. They do the mentorship, and as they are doing mentorship, this is a practical kind of engagement. They support also in screening, and as you saw in my results section, when they came in, the screening increased up to a maximum where they had to pull out and allow the facilities to take on from there. And about the motivation, I'll give an example of this conference. So allowing these mentors to come and share knowledge to the lower health facilities and also in the running sessions was the first motivation. Secondly, in health system strengthening, one of the pillars is financing. So support them with a little SDA as they are supporting this activity. This activity was not for so long. As you saw, from week 3 up to week 12, we had already completed an activity and ready to disengage. Thank you so much.
Yes, you have any question?
Sorry. Thank you for the question. There was a question about whether the big numbers in HTS testing is not a wastage of kits. I want to respond that TASO is entirely an HIV clinic, and we normally have huge HTS targets based on that. So as TASO, we don't actually go out and test everyone without screening. So we basically leverage on the testing modalities of index testing, social network strategy, and APN. And also based on the fact that we normally have huge numbers of VMMC testing targets. Like last year we had 1,300 And according to the guidelines, we're expected to test all those that are eligible before circumcision. So that also contributes to the HTS numbers. So we don't actually just waste kids.
Yes,
thank you.
Let us go to Dasta.
Thank you very much for the questions. I have two questions. First question was, how are we going to measure the impact of these empowered personnel? Number one, when we go to religious leaders, influential personnel, or engage VHTs, we give them information about sickle cell. And, we want to demystify the beliefs within our communities. Some people are attributing sickle cell to bad spirits, witchcraft, and other things of the same sort. So the first thing is to have the myth out of our community. And then all these people are present within the community. So they keep engaging. For example, religious leaders keep engaging the community on a weekly basis, which even a politician cannot have such, a platform every week to engage the community. So how are we going to measure the impact? Number one, we shall have increase in the number of screening of the newborns. And then the number of couples screening for sickle cell before marriage also will increase. And in the long run, we shall have a reduced number of newborns, born with sickle cell anemia within our communities. I think those are some of the indicators which we can easily measure within our reach. And then question number two, someone asked, how is the referral? For example, if you have engaged the community, how do they refer? In the empowerment session, we shall tell you where to find services in case you suspect a child or any other person with sickle cell disease. So we have, within our healthcare delivery model, we have health facilities from Health Center 2, or we can say Center 1, where we have VHTs up to the referral levels. So we also direct these people to where they can seek help, where they can seek care, and we have Health Center, tools at parish levels, and then Center 3s, Center 4s, like that. So we also encourage referral of suspected cases to nearby healthcare facilities. Thank you very much.
Thank you very much. I had requested Chair to allow me, because I had issues with my presentation. These questions are going to be answered in the last two slides of my presentation, which I wanted to present. Next one, the last one. Another one, there's a slide there. Okay. So the accessibility there, I said, if you look there very well, okay, fine. As you can see in my conclusion, with that I prepared, I said HIM has been essential tool that has helped in improving the efficiency, effectiveness, and sustainability of healthcare in Uganda by providing accurate data, supporting decision making, and facilitating better patient care. Where I have been at this, accessed all the big men in this country by seeing what we have been improving in my hospital. Those are the pictures to show. But the next question, next slide, where I said for issues of my innovation, we have to do those three things. I said HIM requires health workers to take note of the following words of wisdom. And this is what I've been using to improve my data management skills. We as health workers, when we document everything, we improve everything, and we achieve everything. Actually, this was my presentation I had prepared, but I had hiccups for God and my country. Thank you very much.
Okay, ladies and gentlemen, please join me to thank all the presenters for this session, for those good presentations they made, and also please join me to thank the chair for sharing this session successfully, and then finally join me to thank everyone who is attending this session. Thank you very much. This is the last speech we are giving, but we have been given instructions that the lunch is already being served, and it's going to be served in the room where we passed. You know that room through which we passed to come here? Just next to the entrance to the first seminar room where we were. That's where lunch is being served. We wish you a nice lunch. I don't know whether we can have a volunteer to pray for that lunch, or somebody down there prayed for the lunch. We shall just go. They prayed. Okay, somebody wants to pray for the lunch.
Bismillahir Rahmanir Rahim. Dear Allah, we ask you to bless the meal so that you can sanctify it to give us energy to walk through the day and also get back to our homes. Amen. Thank you.
Chair, what next after lunch?
Members, we are in camp. So meet.
If you have any patient safety champion who is still out there, you could give them a buzz so that they can come in and we set the ball into motion. And for those who are a little bit interested in the front seats, please do not hesitate to take them up. My name is Dr. Vagala John Paul. I'm a technical officer for Safe Motherhood Ministry of Health, an obstetrician and gynecologist. I just want to confirm if we have our session presenters. Sarah Zalwango, any person? Sarah Zalwango, or a representative here? Twinomjuni Muzaffaru. Excellent, excellent. Stephen Aupal, excellent. Then we have a slight switch in the presentations. We'll have Dr. Peter Wanyera present, and then Nagundi Frida, her presentation has been pushed to a later date. Is Frida here? So you're in agreement with my brother, they're excellent. And then Ivan Segawa.
Someone needs to help us communicate down there. We don't seem to have people this side. Because now maybe people are even around the poster presentation.
Yeah, the public address system is very strong. Very, very strong. But it's making a very important communication so that people can be here in time. Yes, yes. So we are going to start with colleagues who are already here, and I would suggest by 5 we should be done. So we have literally an hour to be done with this session. And may I invite, in the order of availability, Mr. Twinomjuni Muzaffaru. Let's have your presentation up. And that will be followed by Stephen Aupal, and then we shall have Peter Wanyera, and then we shall take the later presentations after a round of questions. Yes. Since we have only, yes, so the presenters, you can come over. Let's have Twinomjuni, Stephen, and Peter. Excellent. Good. So, colleagues, IT, let's have Muzaffaru's presentation up. Excellent. And Muzaffaru is going to present improving the disposal of healthcare waste at Bugamba Health Center for Rampara. I would advise, as we did previously, let's listen into a round of 3. Each presenter will have 7-8 minutes max to make their presentation. And then after the round of 3 presentations, we shall now dive into a round of questions, which will take us not more than 7 minutes still. So my brother Twinomjuni, please, the floor is yours.
It's not my presentation. You check Twinomjuni Muzaffaru. Yeah, good afternoon, everyone. I'm Twinomjuni Muzaffaru. I'm presenting this topic of improving the disposal of healthcare waste at Bugamba Health Center 4. I have 2 co-authors. One is Mutwire Catherine and Dr. Asimwe Abias. Introduction. Healthcare waste is a major environmental and public health concern. And proper management and disposal of heresy is critical to maintaining a safety heresy environment. And at Bugamba, we conducted a comprehensive assessment, and we realized that Bugamba was at 42%, which is quite lower than the set target of the Ministry of Health. And from that, we implemented, we embarked on the improvement objective, where we said that proper disposal of health waste at Bugamba Health Center from 42% in November 2022 to 82% by August 2023. Methodology or methods. A systematic and comprehensive approach was conducted to identify the gaps of proper disposal of healthcare waste. And for that, healthcare waste was segregated at the point of entry, where the waste is generated, where we had the infectious, the non-infectious, the hazardous, and so many. And this helped to ensure that the waste was disposed of in a safe and appropriate manner. And the disposal of healthcare waste was carried out in accordance with local regulations. And we emphasized on the labeling of healthcare waste with appropriate hazard labels or symbols. And we had some tested changes. Here we have one where we talked about the local regulation, and here we also used the green label. We talked about the infrastructure, where we basically looked at even the segregation and many others. Then the results. From the results, you can see we started at 42% and we reached at 82%. And this first annotation was basically about the waste segregation. Initially, people could just put waste in any bin they want. Sometimes we lacked some bin liners, but we had to, in case we had a shortage of bin liners, we could put the liners we have, but we label them. And also the use of stickers to identify each bin was also a good indicator. And also reviewing and giving the feedback was also a good indicator. And we had some enablers where we had the orientation of all health workers and appropriate infrastructure like segregation. Here on segregation, we used to have one place where we could put waste, but we realized that even if community members could come just throw away the waste when they are interested in those polythene bags. So it was also a very big problem. Also, we had another tested change of focal person at each point, and the review feedback at point of disposal and quality improvement meetings. Then on the local regulations, here we use the different labeling of healthcare waste, and we also provided the stickers and pre-disposal review and feedback of focal point through the cleaner on segregation according to the label per point of segregation. Discussion, improving waste segregation practices through staff training and providing appropriate infrastructure, and promoting awareness among the health care professionals and staff regarding the sustainable waste management, and also encouraging the development and implementation of local regulations. and point of generation, point focal person, and feedback mechanism provided the embracing change for healthcare waste management. Lesson learned, training and availability of infrastructure is critical in ensuring the proper waste management and disposal. Then increased collaboration, also teamwork, commitment, good leadership are the key strategies for achieving the desired goals. Conclusion, efficient and sustainable healthcare waste management requires a multifaceted approach that addresses the challenges faced by healthcare facilities. And thus, implementing the improved waste segregation practices, raising awareness among healthcare professionals, and adopting environmental friendly disposal methods. Recommendations, consistent use of color-coded containers, ensuring the adequate infrastructure. Here I mean the place where we used to put our waste, it was now placed under key and lock for people not to just access that place. So we had, actually it was a very disturbing problem because of people could just come dispose of the waste interested in bags. So the place where we put the waste, we had to put it under key and lock. Then regular monitoring and auditing, so we need to have some continuous assessments, collaboration and partnership, also implementation of waste minimization strategies, regular training and education, and public awareness and engagement. Here on public awareness and engagement, we called off the sub-county chiefs, LC3, and other councillors, and we also mobilized some members around the facility. We told them about the dangers of taking those used waste, I mean the bags. Acknowledgement, I acknowledge Minister of Health, you said UHA, Green Label team, Rwampara District team, and Bugamba Health Center for staff members. Yeah. Thank you for listening my presentation.
Yes, a round of applause to Muzaffar. And thank you for really keeping within our time, 7 minutes. Thank you, Muzaffar. You can take your seat. Now next, do we have KCCA, Dr. Sarah Zarango, or a representative? If there isn't any KCCA, okay. All right, so please, you can see. Can I invite my colleague Stephen Aupal to share with us the impact of environmental swabbing in improving infection prevention and control, either regional referral experience using the CQI approach. Stephen, over to you. Please jot down those wonderful questions. After these presentations, we shall then have enough time to interact. Stephen.
IT, and you Lord Aupal Stephen, through chairperson. Good afternoon, everybody. In this room, I just want to inform the chairperson that I'm standing in for Aupal, whom I work with. He lost his father last night, but all the same, we have to keep the ball rolling. Eh? I'm called David Sissie. I'm a senior microbiologist, Lira Regional Referral Hospital. This is the topic we want to share with the impact of environmental swabbing in improving infection prevention and control, Lira Regional Referral Hospital experience using CQI approach. That is a continuous quality improvement approach. And I wish to appreciate my co-authors, Stephen Aupal, Cecilia David, myself, and other co-authors. Hey, IT, what has happened? Next slide. Our sub-theme is patient safety. Introduction. Environmental swabbing is an activity done on high-touch areas at the health care setting to establish the extent of good IPC practices. The environmental swabbing results gave an oversight of the state of IPC at Lira Regional Fire Hospital following isolation of superbugs. When I talk of superbugs, I mean these organisms recently who are resistant to all antibiotics. We refer to them as superbugs. IPC committee initiated the QI project with an aim to achieve 90% compliance by the end of December 2023 using QI approaches. First wait, methodology. Improvement objective is to improve on good IPC practices in selected units or departments at Lira Regional Fire Hospital from 27.3%, which was our baseline, as of June 2021, to 90% in December 2023. Next slide. Methodology. Samples were collected from high-touch areas, which included and not limited to patient beds, patient files, doctor's tables, main entrance door handles, windows for wards, hand-washing sinks, operation theater tables, theater headlamps, trolleys, and health workers' hands. And for information, we didn't grab health workers' hands. We sought verbal consent from them. The baseline data showed a 27.3% compliance. That is out of the 55 high-touch areas we sampled, we had 40 positive cultures across the swabbed departments, and this was used as a baseline to initiate quality improvement journal. Next slide. These are our tested changes. Daily cleaning of ward soak units with close supervision, monthly fumigation of the theater, which was not the case by then, availability of hand hygiene facilities, that's water and soap, environmental swabbing activity, monthly CMEs, that is continuing medical education, IPC, awareness. Involvement of hospital administration in stewardship was the key. So this is a a curve showing progress of 3 environmental swabbing which we conducted in Lira. That is 2021, 2022, 2023. You remember I talked about the baseline of being 27.3, and around 22 there were annotations which we put in place, and we achieved the 46.1%. Then after those interventions put in place, we were at 89.2%. Results. The second environmental swabbing following intervention yielded 41.1% compliance to IPC. That is, out of the 65 high-touch areas we sampled, 35 of them are the isolates or pathogens. Then the last activity, that was the third environment swabbing, yielded 89.2 compliance to IPC. That is, out of 65 samples, high-touch areas we sampled, we had only 7 which grew pathogens. That's what that graph shows. Second slide. Then just it's a table showing the units which we selected and we conducted the activity. The first one was IC intensive care unit. The first column there is the total number of high-touch areas we swabbed and the number positive. In the you can see even 22 and 23. So those are the selected wards but my interest in the theater, if you look at the theater, out of the 13 areas we swabbed, 10 of them had what? Pathogens growing. Even the second activity in 2022, out of the 13 areas we swabbed, 9 of them were what? Positive. Then after those interventions, we swabbed 13 in the 2023, and there was no growth. So which implies the interventions put in place worked. That's what it means. The main concern there is the female cervical ward. Out of 9, 4 were positive. The second swabbing activity, out of 12, 5 were what? Positive. Then after those interventions, when we swabbed the 12 areas, there was no growth. So which implies our interventions did well. worked. Second slide, another slide. This is just a bar chart showing organisms isolated per unit in 3 environmental swabbing activities. I will not go through this because I've already explained the table. It is just a presentation of what I've just explained. Next slide. Then we look at the organism type isolated per unit of what. We had Enterococcus in ICU, Staphylococcus, Klebsiella pneumoniae, Acinetobacter baumannii, Citrobacter frewundi, E. coli, Enterobacter species, then Pseudomonas aeruginosa in those previous progressive years, as you can see those figures. Next slide. So we looked at 2 organisms. We looked at a gram-positive and a gram-negative. So the first, on your extreme right here, we are looking at percentage susceptibility of Acinetobacter baumannii, which is one of the superbugs in Uganda. And you can see there, imipenem is on the lead there at 85.7, followed by ciprofloxacin at 57.1, and piperacillin. You can imagine even there is piperacillin tazobactam is a 71.4. So you can imagine the susceptibility of Acinetobacter being imipenem, yet according to WHO classification of our way, imipenem is one of the reserve drugs. Next slide. The other one is a gram-positive Enterococci fecum, and you can see the susceptibility. Vancomycin leading at 20. Discussion considering the baseline data of 27.3, IPC compliance of 21. The intervention which were tested included those ones, as I've alluded to. Then in the third environment activity, that's what happened. If you remember the tested changes. Next slide. Lessons learned. Environmental swabbing activity has proved to be one of the key interventions in the reduction of healthcare association infections. Basic hand hygiene practices promote good IPC. Conclusion: improved IPC practices at Lira Regional Referral Hospital have tremendously reduced decreased healthcare associated infections, and in turn improved the quality of healthcare service delivery. Recommendations: administration involvement is key in promoting IPC compliance. There is a need to embrace hand hygiene practices. Continuous awareness creation on IPC practices. Environmental swabbing activities are very crucial in infection prevention and control. Therefore, this should be adopted and conducted on a regular basis. Yeah, this is just acknowledgement to say it, and other partners who made this one successful. Thank you, Chair.
So for the initial one,
another round of applause for David. Thank you, David. And I'm very optimistic that we'll have a very powerful discussion because his presentation is very, very intriguing on some of the practices that we have. Now, is a person for KCC here? KCC? All right. So we're going to have a slight adjustment. We're going to have all the 4 presentations, and then we discuss at once. Okay? KCCA is not here, so we shall have 4. We're supposed to be 5. Now, allow me invite my brother, Dr. Peter Wanyera. And Peter, feel free to say a little bit about yourself, a little bit of profile. It will really help people to know you. Now, Peter is going to talk to us about increasing percentage of pregnancy detection among women admitted with medical conditions in Bufumbo Health Center 4. A little bit of intro will help it.
Thank you so much, Chair, and all of the members present here. My name, I'm Dr. Peter Wanyera. I'm a gynecologist from Mombali, and locate me at that health facility currently in terms of coordinates.
So, by the time the CAP or the district level meeting is just now harmonization.
I'm going to tell you something about improving pregnancy detection rates among women admitted at that health facility with medical conditions. And we use the sample called urine, which is also an infectious material which needs to be disposed of. And that's my name. My co-authors were Nagodi Frida, she's here, Nambala Estaf with UHA, and Margaret Atimwe, midwife. Next slide. So, it is known that early pregnancy detection stands as being very pivotal in reproductive health care and holding profound implications for both the mother and the baby. So it's very important that early initiation and detection of pregnancy complications may arise if no interventions are done early. So data review at that facility revealed that only 30% of pregnant women presenting that facility had their ANC for the first time in the first trimester. That's within 13 weeks, against the recommended standard of 60% of the total first ANCs must come in the first trimester. So we came up with an objective to address this gap that increased the pregnancy detection among mothers, women admitted with medical conditions from 0% that was in March to 100% in December last year. And this was done as follows. So we did a fishbone analysis where we identified there were gaps in identification of who were these eligible women and how do we document them when they are admitted on the wards with this. So we came up with eligibility criteria, which was any woman of reproductive age that's between 15 and 49 years. And this woman must report that she has taken 14 days from the time of her last menstruation period when she's admitted with a medical condition in that facility. So we took through the health workers who were working with that word about HCG testing using urine, and also we supplied the urine HCG strips to them to be able to attend these mothers. So the teams were set out. Whoever was positive was being linked to antenatal clinic straight away, and the health workers did this massively because it was reducing their workload. You have 7 patients, 2 tested positive, automatically remain with only 5 patients. So there was no health worker who hesitated doing an HCG for whoever was eligible. Next slide. So these were the results. In March last year, we were having 0 women on that ward who were tested urine HCG positive. The activity was not on. So in April, you were able to see that 7 women were eligible and 2 turned out to be positive. In May, we had 15 and 2 turned out to be positive. The sensitivity there was very low, the screening. In June, we had 20 women who were eligible and 6 tested HCG positive. In July, we had 7 eligible women, 4 were positive with urine HCG. And we have 6, 3 positive in August, 13, 6 positive. We had 13 again, 4 positive. And lastly, in November, we had 10 and 8 were positive, giving us an 80% number of mothers who tested urine HCG positive. And those are the trends. Those fluctuations where there were some few issues of change of staff. Next slide. So we noted that there was a progressive improvement in detection of HCG in women of reproductive age. That's from 0% in March to 29% in April 2023, and this progressively improved up to 80% in November 2023 with the continued supply of strips. Trends where you were able to see fluctuating figures, like where we had like 30%, staffs had switch over, so the others who came in, they could not really take it seriously, the criteria who qualifies. Next slide. Next. So what we learn from here, every leadership and coordination plays a significant role in addressing the gaps identified our health facilities, and it's very important that at every point of service delivery, we need to look out for possible pregnant women in our community. Next. So in conclusion, it's important to screen women of reproductive age for whatever service they come for the health facility, and HCG can be taken as being routine of these services at every entry point. Next slide. So we recommend that every woman of reproductive age should receive screening if eligible for early pregnancy detection and complication preparedness or readiness. And all health workers need to have knowledge that HCG screening for all women of reproductive age can be done by anybody, and it's a simple technique. Next slide. We thank USAID, UHA, and the staff and the leadership of the facility and all the other stakeholders. Thank you so
much. Thank you, Peter. Yeah, very interesting study there. Of course, as our rates, all the number of women who seek all visit for first ANC, first trimester keeps low. I know one of the questions that will come out, how do we translate this into getting into the community to improve our numbers of women who attend first ANC, because it's very low. But thank you. Let's keep those questions. We're going to interact. Any person from KCCA or representing SARA? All right. So we are having our last presentation for this session. All right. And I'm going to invite my brother Ivan Segawa, who will also share a little bit of himself, and is going to share with us the launch of the Quality Improvement Collaborative for the Catalyst study. Ivan.
The meeting that should bring all DHB
thank you, everyone. And I hate to stand between you and your break, so I'll try to keep it as short as possible.
This meeting is too short. It may not give you the results you need.
All right. Before I begin, my name is Ivan Segawa. Dr. Bagala here has not told you, but I was in the same primary school as him. He was very stubborn. But anyway, that's not what I've come to present about. I'm here representing the project director and the project team from Mosaic Project. Mosaic Project is maximizing options for advancing informed choice for HIV prevention. So it's a project that is going to really work in the space of HIV prevention, but most importantly, we're working together with TASO and the Ministry of Health as our local implementing partner. My name is Segawa Ivan. I work both as the Catalyst Study Coordinator and QI Advisor. I'm here representing the Catalyst Quality Improvement Collaborative. Next. Oh, there's a lady seated there. She's from TASO, and one of the slides you'll see that we have a national QI coach, and she's been really supportive in this project. So most of you have seen many abbreviations, and we have a poster down in case you need to ask any more questions. But one of the abbreviations is Catalyst. Some of us who did, or most of us who did chemistry, you know a catalyst is something that speeds up a reaction. Today morning we had Dr. Rotha Cheng, the Minister of Health, saying that 2030 is close, so we need to do something, we need to speed up. So this is a study that has been brought in to speed up the access to new HIV prevention products. And by new HIV prevention products, most of us have heard of oral PrEP, where people swallow pills every day, and this has been modified to event-driven, where people take once in a while. But I'm here also to present some of the products that have come into the country. One of them, I'm holding it in my hand, but that's not where it's supposed to be. This is a, we're all scientists. This is a vaginal ring that contains antiretroviral drug called dapivirine, and it's worn for a month. And this was registered in Uganda, and it's going to be used across the sites that will be used. We also have the injectable cabotegravir, which is a 2-monthly injection that has also been brought in. So the Catalyst project is really working with products that have been registered in Uganda. And now the challenge that we have is making sure that as many people as possible can access this product. But it's also part of the Mosaic project, and we are targeting women for now across 28 sites across 5 countries, including Uganda. You may notice from the countries, Kenya, Lesotho, South Africa, Uganda, and Zimbabwe, that those are the high HIV burden countries, and we all know that these young women are contributing to almost a third of new HIV products. So Catalyst is a study, but I'm here to present about the Quality Improvement Collaborative, where we're using quality improvement methods to refine what we call a service delivery package. So we're not only targeting the women, we also have to make sure that the health system is ready, that the providers are ready, that the community is ready for us to roll out these new HIV products. Next. So this is what you might see, some layers there. But we're not only interested in giving women products and handing them over. We have to make sure that the system is improved. Do we have the tools, the registers, have they been updated? Are the providers or our healthcare workers trained to provide? Because we've been used to one product, and when you walk into a facility, you have nothing but to be given oral prep, maybe, and condoms and other things. But now we're going to be in an era where young women come in and there are 3 products, and you need to discuss with them, and they choose the product that will work for them. So we have to make sure that every system or every layer is ready. And the way we're going to do that is to learn through the quality improvement methods to make sure at the end of the project we have a package that informs the Ministry of Health how these PrEP choices will be rolled out. Next. So these are our methods, and we have the Quality Improvement Collaborative working under the Catalyst study, and we have 7 sites, 2 in Western Uganda, 2 in Northern Uganda, and 3 in Eastern Uganda. So I would love to show some of the run charts, but unfortunately, when we submitted this abstract, we only had data for the QI charter meeting, the training, and the pilot testing, and that's what we're going to focus on for today. Next. So for the charter meeting, and this is early on last year when we were starting, and this was to give us an overview. If you were given the mantle or the job to start a collaborative, what would you do? So one of the things we started with was the QI charter meeting, where we were really looking forward to making sure that we create a roadmap. So we invited different stakeholders at national, Ministry of Health, regional, but most importantly, the users, because sometimes we want to design QI projects and we don't involve the end users. So we brought all these people together to make sure that we agree on an improvement aim, objectives, collaborative, and a structure. And one thing that stood out is making sure when you're holding these charter meetings, you invite all the whole stakeholders, make sure that you have buy-in. Because sometimes when we are implementing our QI projects, there's resistance, and some things we need to work on. So make sure all these stakeholders are available, and you share with them all these materials before you begin your projects. Next. So the aim, and allow me to read it, is to optimize the delivery of an enhanced service, enhanced choice-based PrEP delivery package by 2025. So the Catalyst study, unfortunately, will end next year, but we hope that the lessons we have learned can be translated to all the sites. So we're only doing it in 7 sites, but at the end, the ministry wants to roll it out to 650 facilities in Uganda that are offering PrEP. So they are depending on many of the lessons that we'll learn along the way, and we'll share in this and the upcoming conferences to make sure that we have the lessons when we're implementing. So one of the things we wanted to make sure are the young women getting informed choice. So it's no longer you come in and they hand over a pill bottle. Do I have that discussion with you about the different PrEP methods so that you're able to choose what works for you? We're going to make sure that people, or one of the things we're working on is to make sure that people return for month 1 refills. because we've seen from many facilities, people are excited the first time and then about 10% return at month 1. So we want to make sure we address that. But most especially, if we are offering quality services, it will be seen in the positive experiences young women are reporting, and that will ultimately help us increase the uptake and continued use of PrEP. So those are our core objectives. The additional ones are focused on integrated services. So we don't only need to give you PrEP or HIV prevention. Do you need STI services? Do you need GBV? Do you need family planning? And that's something we'll also focus on. Next. So this is a structure. We're supported by the global team, and we're working together with 7 QI coaches. So I am the QI advisor, and we have our QI coach in the house today, and we are working together to make sure we develop lessons. Next. So the training, and this was one of the areas where we had a lot of time spent. We wanted to make sure that we have the right capacity at the facilities. And we had to go through a bunch of topics that many of you have done when you are launching your collaboratives. But most importantly for us is, how do you make the trainings fun? Some people will tell you we're tired of listening presentation after presentation. So how can you make QI fun so that people can easily digest them? So we devised and came up with some group exercises, like we had Lego games or building blocks, where people would learn about the PDSA. Would have a tennis ball where you pass it around and we'll ask you, how can you reduce the time? And then we also have process mapping and use sticky notes. And these were practical and helped teams grasp some of these concepts. And those were the lessons we hope to share with. Next. We also did a pilot testing of indicators from the ones that we shared earlier. We wanted to make sure that we're capturing the right data. So some of our indicators were unable to do because we found that they're not feasible. But most importantly for us is, when you're developing your indicators, or make sure that you involve the right people. Sometimes we design a nice document and we go to collect the data, and we're actually addressing a problem that does not exist, or we don't have the right data. So that's something that was important for us to test the indicators. Next. So in conclusion, and through the other lessons we'll share in coming conferences, we hope that whatever we learn, we will share, most importantly. We are currently testing change ideas through PDSA cycles, and whatever will work, we'll share with the ministry such that they can scale up and sustain across the other facilities. Thank you.
Thank you. Now, time to interact. Let's have a round of first 3, and then we shall see how the time. Yes, so 1, 2, 3. Let me balance gender here. 1, 2, 3. I'll get you on the next load, my brother.
There is one here. Thank you, Chair. I'll ask one question to one member, then the other, if there will be time, will be directed to Ivan, but I'll direct my question to David, who is representing Stephen. Thank you, David, for that presentation. By all means, it's a wonderful presentation with quality documentation and quality presentation. But I have some concerns. It's a very wonderful study, but what was the context, David? In your introduction, we didn't appreciate the context, because what was the basis for initiating this wonderful environmental swabbing? Of course, right now we are talking about antimicrobial resistance, we are talking about the suffering of patients. So was it informed by your observation that patients were having extended periods in the hospital of admission because their treatments were not working? And then you are wondering what is going on? What was the context, please? I would like to understand, okay? And then with the conclusion, these wonderful things that we do, we come and present them at the QI conference, and then they just die off. It doesn't settle well with me, the sustainability component. So I would like to know, I observed your recommendations and I appreciate them. But those recommendations, what are those at the end of your project? what were those measures that we can say are owned by Lira Regional Referral Hospital for sustainability? Have you come up with, can I say, commitment of management to keep funding these swabbing exercises per annum, and is in the budget? Can it be evidence? Can it be, is there evidence? Have you come up with a checklist or a tool to ensure that you carry out this activity always, that you observe hand hygiene practices often, to continue collecting this data and make it relevant to ensure that you follow up? Please share with us the sustainability, that I can go to Lira today and I find them in practice anytime. Thank you.
Peter Okello-Deke is my name. I am the administrator of Lira Regional Referral Hospital. First of all, I just want to inform the House that in here is the Senior Principal Nursing Officer, the mother in charge of the nurses in Lira, Sister Judith. And with her is another guru who will be presenting another item, I believe, tomorrow. So what I want to bring out is to supplement what had been presented. I want to say what Lira saw was there was a lot of resistance in terms of medications to most of the prescriptions that were done. And I believe you that across the board, right now, STIs are a problem. You find everybody is coming and it is a repetitive problem. That was one thing which was an eye-opener for us, that what could be causing this? Two, you'd always see the referrals from the lower facilities who are following the same trend. So it is from that picking up that the team said, no, we need to do something. Now, in terms of the sustainability, the sharing, and the commitment of management towards this kind of activities, it's why I'm personally here representing the director and personally being part of the team. That this we wish to continue to happen. Immediately this was sanctioned. We have what we call a hospital parliament, in quotes. The hospital parliament constitutes of heads of sections, units, and departments that meet every Wednesday of the week. This issue was brought out from the prescribers, that what is happening? And then we had to charge the lab to say, what can you do? Especially having the relevant equipment. And that's when they were sanctioned to do the swabs. After the swabs, they presented these findings to the parliament. You've already understood what I'm talking about, the what? The parliament. Now, from that, we're able to pick and say, every quarter, we should be able to do something nearer to doing a swab, so that we reduce on our medicine costs, and then be able to dispel some of the medications that are no longer relevant. And that already has been communicated to the prescribers. In short, other details can come. I was very interested in Ivan's, presentation about this other new research on how HIV medication is, especially PrEP and PEP. Now, when you look at the methods, how you're able to come up with the research, I think this is something that needs to be seriously, people need to be informed. Because by and large, already you'll see in the moonlight clinics, when we are trying to follow, especially for the commercial workers and their what? Customers, it's a big problem. So we need to get it such that already we can begin communicating this kind of message and be able to have the PEP and PrEP move on. Thank you.
Thank you very much. My name is Dr. Nuampire Maria Prima, and I'm the National QI Coach working with TASO Uganda on the Catalyst study. My question goes to Muzaffar. Thank you for the wonderful presentation. You mentioned that the waste disposal bins were put under lock and key at some point. Now, my initial worry when you mentioned this was accessibility. We've seen cases in hospitals where we have equipment, but because the healthcare workers are not aware, we have these things expiring, or we have waste being disposed elsewhere because the waste disposal bins are not accessible. Now, as I was still worrying, clearly I saw that the change idea worked basing on how your run chart looked like. So my request is that you please share with us how you managed to balance out this lock and key method, which minimized waste while also ensuring accessibility. Thank you.
Yes. Now, let's get the responses. If you can be just on point, that would be good, because it's exactly 5. Just respond. I know Ivan has something to say, Muzaffar, you have something, and my brother David, you have something, isn't it? So David, start. Just be on point. Don't make another presentation. There is a mic next to you there.
Sorry. Well, Dr. Uma, my boss, the PHA, the hospital director has simplified my work. The reason why, which triggered the environmental swabbing, was we realized patients were overstaying on the wards, as my boss said. So basing on this one, basing on our data, we saw ampicillin resistance on the rise. So it is from that basis that we initiated this activity supported by EDI. However, even these recommendations, we shared them with the Medicine and Therapeutic Committee, and we told them to regulate the purchase of ampicillin in the meantime. That was in Parliament, as my boss said. Then Lira Regional Referral Hospital is one of the hospitals which have managed to develop an antibiogram, which is reviewed on an annual basis. Based on the data we have, so I think I can stop there. Yeah.
Yeah, thank you for the good question. Unfortunately, I didn't get where your names. You asked about the issue of key and lock. Yeah, it was a serious issue because when we identified that problem, we sat as a team, the whole health facility team, and we have 4 porters. We had the in charge of them, one of them became the in charge, and each department had a representative in these QI meetings or teams. And from there, some responsibilities were given to the head of the porters or the cleaners. And the fellow cleaners were also given a key. So we manipulated the key such that every cleaner has the key, and they are the people who takes the waste. And again, it's these cleaners that helped us to identify some areas where the waste segregation was not being done properly. Because once they reach, like in the department, they look at their waste segregation, and in meetings they could give the feedback, and we had to improve. Thank you.
Good. Ivan.
Well, thank you for the questions. Yes, I agree that we need to do more to reach out to the communities that have vulnerable individuals to HIV. So some of the things we've done through QI, we've been able to focus on health education and community sensitization, most especially in the catchment areas where the study is being done. And we recently had a QI learning session where we shared some of the interim learnings with the Ministry of Health. And I'm excited to share that the Ministry of Health is going to purchase some rings and injectable cabotegravir that will be rolled out at the different sites so that we can really increase access to these new HIV prevention methods. Thank you.
Thank you. Now, my brother Peter, my question is, how do you cascade the powerful intervention you did within a facility to the local maternal and neonatal system of Elgon? looking at the community and how can we increase on the number of women who attend ANC in their first trimester, borrowing some learning from your study?
Thank you so much, Chair, and for that wonderful question. From the analysis, what we were able to detect in our health facility, the whole team is aware about. We presented this at our facility level, and one of the things we have known that there are so many pregnant women outside there. So one of the modalities is we have been able to integrate this into our routine integrated outreaches, which involve EPI, HIV testing, and whatever. And we have started now harvesting other women from the community. When we go out even to vaccinate babies, we are coming with some positive pregnant women outside there, even mothers who come to even do their, vaccinate their babies. And we do this in the nearby, commonly our outreaches and the nearby homes. And the challenge was, how do we get the sample? So there are community homes around. We talk to the people. They are gazetted static sites whereby these people go. So they are well stipulated, and there's a special site whereby the sample could be obtained and the test can be done and the results brought. Thank you.
Thank you. Let's have another round of three. My brother there, my sister next to him. My brother here. I'll take the sister there. My brother. Yeah, thank you.
Yeah, thank you so much. My question was going to Peter. Quality improvement is supposed to be enhancing systems. And in your submission, you did say that when you had changeovers, you had missed opportunities. So in this case, what happens to these mothers? Okay, do you have a system to track them and ensure that they are at the end of the day receiving the HCG test? Two is to Ivan. How do we leverage on the learnings from the National PrEP Collaborative